Welcome to Conquer Pathology with Dr. P. Today we are diving deep into Robbins Chapter 15, the lung. What you see on screen is our masterclass blueprint. Let's get straight into it. Moving to our first block, we have Module 1, titled The Scaffold and the Collapse. We will start with a normal histology recap to set our foundation. Then we will cover congenital anomalies, specifically focusing on foregut cysts and sequestration. Next up is Atelectasis, where we'll break down the big three mechanisms you need to know. Finally, we tackle ARDS and diffuse alveolar damage or DAD. For those tracking your competencies, this module covers NMC competencies PA 3.5. Next is Module 2, the Airway trap, which is entirely dedicated to obstructive diseases. We will introduce the obstructive paradigm first. Then we dive into emphysema, paying special attention to alpha-1 antitrypsin deficiency. We will also discuss chronic bronchitis and the clinical significance of a read index greater than 0.4. We will break down asthma and the crucial Th2 axis. We wrap this section with bronchiectasis, including its high yield association with Cartagener's syndrome. This aligns with NMC competency PA 13.4. Our third module is the stiff lung, dealing with restrictive and interstitial lung diseases. We will explore idiopathic pulmonary fibrosis and the classic UIP pattern. Next we cover NSIP and COP. We will thoroughly review the pneumoconiosis, including coal, silica, asbestos, and berylliosis. We finish the hour with sarcoidosis, hypersensitivity pneumonitis, and PAP. This module hits NMC competencies PA 13.3 and PA 13.5. Kicking off our second hour is Module 4, titled The Pulmonary Plumbing. We will discuss pulmonary embolism, hemorrhage, and infarction. We will classify pulmonary hypertension, covering the WHO groups and the highly tested BMPR2 mutation. We will also look at diffuse alveolar hemorrhage syndromes. This block correlates with hemodynamics and NMC competency PA 13.5. Module 5 is all about the invaders, focusing on pulmonary infections. We will contrast lobar versus broncho patterns and community-acquired bacterial pneumonia. Then we cover atypical pneumonias. Next we review the pathology of a lung abscess. We will also highlight opportunistic and ICU pneumonias, specifically looking at pneumocystis and fungal invaders. This covers NMC PA 13.1 and PA 13.2. Finally, Module 6 wraps up the masterclass, and it is titled Space Invaders. This section covers tumors and the pleura. We will break down the big four carcinomas: squamous cell carcinoma, adenocarcinoma, small cell lung carcinoma, and large cell carcinoma. We will briefly touch on carcinoids. For pleural pathology, we will discuss pleural effusions and apply Light's criteria. Next, we look at pneumothorax. We close out the entire section with malignant mesothelioma. This final module perfectly aligns with NMC PA 13.6 and PA 13.7. Let's open Chapter 15, the lung. This module is titled The Scaffold and the Collapse, and it specifically maps to the NMC CBME competency PA 13.5. On this first slide, you can see our core topics for today. We will start with the normal alveolar histology recap, move into congenital anomalies like foregut cysts and pulmonary sequestration, break down the big three of atelectasis, and finish with ARDS and diffuse alveolar damage. Let's start with a case vignette. A 28-week premature infant who is fighting a losing battle against physics. The neonate is at 28 weeks gestation and within 2 hours of birth starts working furiously to breathe. Clinically, we are seeing nasal flaring, intercostal retractions, and grunting. You order a chest X-ray and it reveals diffuse ground glass opacities. So I want you to ask yourself, why is this baby fighting a losing battle? The answer is that they are missing a single molecule produced by a single cell type. Keep this in mind as we explore the normal histology. We need to understand that the lung is a hyperdelicate, high-pressure interface. Look at these numbers. You have 100 square meters, that is the total surface area of this interface inside you. but the physical barrier separating the environments is unimaginably thin, just 0.5 micrometers. This incredibly delicate scaffolding serves one vital purpose: keeping the dirty, dust-filled outside world completely separated from the sterile, life-giving blood. When this interface breaks, people die fast. Let's look at this boundary closer. Oxygen must pierce 4 strictly ordered layers to reach the blood. First is the alveolar epithelium, which forms the direct boundary to the airspace. Next, oxygen crosses the interstitial space, a tiny gap housing delicate collagen, elastin fibers, and wandering fibroblasts or mast cells. Remember that 0.5 micrometer alveolar capillary membrane dimension? This is where it matters. After the interstitium, we hit the basement membrane, providing the structural support of the endothelium. Finally, oxygen crosses the capillary endothelium, which is lined by tightly packed, continuous endothelial cells to reach the bloodstream. Now, who builds this wall? This slide introduces us to the 2 distinct cellular roommates that pave the alveolar wall. First, the type 1 pneumocytes, which are essentially the floor tiles. In terms of morphology, they are extremely flattened and squashed to allow rapid oxygen diffusion. Here is the examiner's paradox. Type 1 cells cover 95% of the alveolar surface area, but they make up less than 50% of the total cell count. Their lifespan is terminally differentiated. If they are destroyed by a virus, they cannot divide. Then we have their roommate, the type 2 pneumocyte, or the caretakers. Their morphology is completely different. They are cuboidal, plump cells sitting in the corners of the alveolus. Their examiner's paradox? They cover only 5% of the surface area, but they are the absolute MVPs of the lung. Why? Because of their lifespan abilities. They are the stem cells of the lung. When type 1 cells die, it is the type 2 cells that proliferate, differentiate, and pave over the damage. Our next slide details exactly why these type 2 pneumocytes are the MVPs. They synthesize surfactant and drive tissue regeneration. For surfactant production, their cytoplasm is packed with lamellar bodies, which act like tiny flat packs. These bodies secrete pulmonary surfactant, specifically dipalmitoyl phosphatidylcholine, coating the inner water layer to dramatically lower surface tension. Their motto is essential: I dry, I clean, I regenerate. This brings us to the regeneration motif. When those type 1 floor tiles are nuked by pneumonia or smoke, type 2 cells act as the lung's primary stem cells to rebuild the scaffold. This is so critical that examiners will weaponize alveolar cellular biology against you, which brings us to Dr. P's exam cheat codes. If the MCQ asks, which cell is responsible for the regeneration of alveolar epithelium following acute lung injury? Do not pick type 1. The answer is always the type 2 pneumocyte. And if the MCQ asks, what is the ultrastructural hallmark of surfactant synthesis? The answer is lamellar bodies. Lock those in. Let's return to our premature infant from the case vignette. Physics explains the premature infant's respiratory collapse perfectly. Look at Laplace's law on the screen. P equals 2T divided by R. P is the collapsing pressure, T is surface tension, and R is the radius. In a tiny alveolus with a small radius, the collapsing pressure becomes intensely high unless the surface tension is reduced. Because our baby was born at 28 weeks, they have no type 2 cells, which means no lamellar bodies, leading to no surfactant. This results in a high surface tension. Because of this, the baby's lungs collapse at the end of every single expiration. Finally, let's wrap up this recap by talking about how the lung has built-in fail-safes. Secret anatomical tunnels allow air to bypass blocked airways, and these are called the pores of Kohn. The mechanism is simple. They are tiny doorways between adjacent alveoli. Their clinical relevance is huge. They function as the secret ventilation tunnels of the lung, allowing vital airflow to bypass a blocked upper airway and keep the architectural scaffold inflated. Next, we are targeting an extremely high-yield topic. We are looking at the rogue anatomy cysts and sequestrations as part of our masterclass. As you can see on the screen, we will be focusing on lung tissue that develops anomalous branching and demands a rogue systemic blood supply directly from the aorta. Let's jump into a clinical scenario. Take a look at this case vignette. Our patient is a 20-year-old college football player. His presentation? Completely asymptomatic. In fact, he runs 10 kilometers a day and is only here for a routine sports physical. However, his imaging finding reveals a dense 5 cm mass situated at the base of the left lower lobe. Moving deeper into this vignette, we discovered two highly suspicious characteristics about this mass. First, there is zero bronchial communication. It is completely cut off from the airways. Second, it has a direct systemic blood supply via an aberrant branch coming straight off the thoracic aorta. So I want you to ask yourself, what is this rogue tissue? To answer that, we have to look at embryology. Congenital anomalies of the lung happen when respiratory budding fails. Look at the two steps on the screen. Step 1 is normal budding from the primitive gut tube, but in step 2, we get the disconnect or the pinch off. Depending on how and when this disconnect happens, we end up with one of two rogue structures, either foregut cysts, which are fluid-filled and completely detached, or pulmonary sequestrations, which consist of rogue vascularized tissue. Let's examine suspect number 1, bronchogenic cysts. The mechanism here is a detached architectural failure. Because they are disconnected from the tracheobronchial tree, what is the result? They do not fill with air. Instead, they fill with clear mucinous fluid. If we put this cyst under the microscope, the architecture tells the whole story. The wall looks exactly like a normal bronchus. It is just trapped and detached. Notice the specific layers. We have our ciliated pseudo-stratified columnar epithelium, a distinct layer of smooth muscle, and these neat plates of hyaline cartilage. It has all the right building blocks, just in the wrong place. Now let's talk about suspect number 2, pulmonary sequestration. I like to call this the nepo baby of the thorax. Unlike normal lung tissue that does the hard work of normal gas exchange, this rogue tissue has declared independence from the respiratory system. It has no airway connection, yet it demands a direct, high-pressure arterial allowance directly from the thoracic aorta while doing none of the work. It provides absolutely zero gas exchange. You must know how to differentiate the two types of sequestrations. Here's the diagnostic lineup: extralobar versus intralobar. For extralobar, think infants. This is usually found on congenital or prenatal scans. It has its own separate visceral pleura and sits external to the lung, 90% of the time on the left near the diaphragm. Crucially, 60% of these cases are associated with a congenital diaphragmatic hernia, and venous drainage goes to the systemic azygous system. Compare that to intralobar. This presents in older children or adults, like a 20-year-old patient. It is enclosed within the normal visceral pleura and sits inside the normal lung parenchyma. Clinically, it presents with localized recurrent pneumonia. Most dangerously, it drains via the pulmonary veins, which can cause a left to right shunt. To make sure you never forget this, here are Dr. P's exam cheat codes. Extralobar is the external infant. It is born outside the lungs pleura and is spotted early in babies. Intralobar is the inside invader. It is hiding inside the normal lung pleura, silently waiting until adulthood to cause recurrent infections. Let's bring it all together and resolve our case vignette. We had a 20-year-old athlete with an enclosed lung mass and a direct aortic branch supplying it. Our verdict? The diagnosis is an intralobar sequestration, the inside invader. To summarize today's masterclass, foregut cysts represent an architectural failure resulting in detached fluid traps. Sequestrations present a vascular and functional failure acting as rogue systemic parasites. Let's learn about the three pillars of atelectasis. As you can see on the screen, our focus is on mechanisms, clinical diagnosis, and exam mastery. Looking at our anatomical diagram, we will cover the entire respiratory tree, from the carina to the right and left main bronchus, and all the way down through the lobar bronchi and segmental bronchi. Let's get started. Let's set the scene with a classic clinical vignette. The 2 a.m. surgical ward call. A 58-year-old man underwent an open cholecystectomy 36 hours ago. He suddenly spikes a fever and exhibits tachypnea. His vitals are a temperature of 101 degree Fahrenheit and a respiratory rate of 28 beats per minute. Looking at the exam findings, auscultation reveals completely absent breath sounds at the right lung base and percussion is dull. The radiology read shows right lower lobe opacification and crucially the trachea is visibly pulled toward the right side. What just happened to his lung? We will answer that by the end of this lecture. First, we are defining atelectasis as the loss of lung volume, derived from Greek meaning incomplete expansion. Atelectasis is the loss of lung volume caused by the inadequate expansion of air spaces. Look at this diagram here. Notice the stark contrast between the properly inflated alveoli and the deflated or collapsed alveoli. We divide this into two main categories: neonatal pathology, which is a primary failure to inflate at birth, and adult pathology, which is a secondary collapse of a previously inflated lung. When this collapse happens, we face the twin physiological penalties of alveolar collapse. Penalty 1 is pathway A, the ventilation perfusion mismatch zone. Here, blood flows past deflated alveoli without picking up oxygen, acting as an intrapulmonary right to left shunt. Penalty 2 is pathway B, the bacterial resort. Deflated wet lung tissue provides an optimal breeding ground for pathogens, rapidly culminating in pneumonia. Moving to the architecture of pulmonary collapse. Robbins classifies acquired atelectasis into three primary mechanical pillars. First is resorption, where the mechanism is an airway blocked. Second is compression, where the mechanism is external pressure. And third is contraction, where the mechanism is cicatrization or scar. Let's break these down. Pillar 1 features the obstructive vacuum of resorption. For its pathogenesis, complete obstruction prevents air from reaching distal alveoli. Trapped oxygen and nitrogen are absorbed by pulmonary capillaries over hours, collapsing the alveoli like vacuum-sealed bags. In terms of mechanical physics, the trachea and mediastinum shift toward the affected side due to localized vacuum. Classic clinical triggers include postoperative pain leading to mucus plugs, bronchial asthma, and foreign body aspiration. For example, a peanut in a toddler's right main bronchus. Next is pillar 2, which features external eviction via compression. The pathogenesis here, the airway remains patent, but the pleural cavity is flooded with fluid, blood, or air that physically crushes the lung parenchyma. The mechanical physics. The excess volume acts as a hydraulic press and the mediastinum shifts away from the affected side. Classic clinical triggers include massive pleural effusion from congestive heart failure, hemothorax from trauma, and tension pneumothorax. Finally, pillar 3 features irreversible straitjacketing via contraction. Looking at the pathogenesis, focal or generalized pulmonary or pleural fibrosis, also known as cicatrization, physically hampers full lung expansion. The scar tissue shrinks as it matures, binding the lung. Pay close attention to this crucial distinction. Unlike resorption and compression, contraction atelectasis is completely irreversible. Classic clinical triggers include severe chronic tuberculosis, radiation lung injury, and end-stage interstitial lung disease. To lock in the visual, let's review the mechanical physics of mediastinal deviation. Simply remember these three forces. The vacuum pulls in resorption, the hydraulic press pushes in compression, and the straitjacket shrinks in contraction. Now for high-yield review, let's look at the definitive diagnostic metrics for your exams. For resorption, the primary defect is airway obstruction. The shift direction pulls toward, it is reversible, and vignette buzzwords are postoperative mucus plug and foreign body. For compression, the primary defect is external pressure. The shift direction pushes away, It is reversible, and vignette buzzwords are CHF effusion and tension pneumothorax. For contraction, the primary defect is fibrotic cicatrization. The shift direction is permanent distortion. It is irreversible, and vignette buzzwords are tuberculosis and radiation injury. This matrix is vital for mastering the highest yield exam trap. Here is Dr. P's exam cheat code. The single most tested concept on USMLE and NEET-PG clinical vignettes regarding atelectasis is mediastinal shift direction. Rule 1. Resorption equals pulls towards the lesion due to the vacuum effect. Rule 2. Compression equals pushes away from the lesion due to the mass effect. Rule 3. Contraction equals permanent due to scar effect. My call to action for you today: match the direction of the tracheal shift to the mechanism of collapse. Let's bring this back to the hospital by integrating ward management to prevent collapse. Notice this exact sequence. Post-op pain leads to shallow breaths. This results in no ciliary mucus clearance, which causes mucus plugging. This leads to resorption atelectasis at 24 hours and ultimately post-op pneumonia at 48 hours. Our clinical intervention: prescribing adequate opioid analgesia and mandating incentive spirometry is not just about comfort. It is the primary intervention to prevent mechanical lung deflation and secondary bacterial colonization. Finally, we are solving the midnight post-op mystery. Here's our patient callback. The 58-year-old post-op cholecystectomy patient with right lower lobe opacification and right shifted trachea. The diagnosis is confirmed. Pillar 1: resorption atelectasis. The mechanism: pain prevented deep breathing, leading to a mucus plug in the right lower lobe bronchus. The trapped air resorbed, creating a vacuum that pulled the trachea to the right. Our immediate order is to implement pain control, aggressive incentive spirometry, and chest physiotherapy to break up that mucus plug blockage. Next, we are moving into module 1.4 of our masterclass, and today we are tackling a critical killer, ARDS and diffuse alveolar damage or DAD. As always, this is engineered for high yield mastery for your exams and ward rounds. Let's get right into the ICU. Look at case vignette on your screen. You have a 34-year-old female, ICU day 3. Her admission diagnosis: severe acute necrotizing pancreatitis. Suddenly there is an event. She develops profound dyspnea, cyanosis, and tachycardia. Look at her monitoring systems. Her heart rate is spiking at 145 beats per minute. Her SpO2 has dropped to a critical 78%. We draw labs. Her PaO2 is a dismal 50 mmHg, and that is despite being on a 100% oxygen face mask. Imaging reveals a bilateral white-out chest X-ray. But crucially, her hemodynamics show a normal pulmonary capillary wedge pressure or PCWP. What does this tell us? Her heart is not failing. This is a primary lung disaster. To understand this disaster, we must bridge the clinic to the microscope. The clinical syndrome you see in the ICU is called acute respiratory distress syndrome or ARDS. But the microscopic reality, what we see under the lens as pathologists, is diffuse alveolar damage or DAD. To diagnose this, we use the Berlin definition. It is acute hypoxemic respiratory failure combined with bilateral infiltrates that are strictly non-cardiogenic. And the math you must know for the boards: the PaO2 to FiO2 ratio is less than or equal to 300 mmHg. What triggers this? It all comes down to a systemic inflammatory storm. As you can see, the number one cause worldwide is sepsis, but it can also be triggered by acute pancreatitis, just like our vignette patient, severe trauma, gastric aspiration, and as we have all seen, viral pneumonias like SARS-CoV-2, COVID-19. This inflammatory storm initiates what I call the endothelial-epithelial crossfire. The trigger attacks our highly delicate alveolar capillary barrier from one of two fronts. We have the blood side injury hitting the capillary endothelium, which is caused by things circulating in the blood like sepsis, trauma, or pancreatitis. Or we have the air side injury attacking the alveolar epithelium directly via inhaled toxins or severe viral pneumonia. Let's break down the pathogenesis step by step. Step 1 is the alarm. The primary actor here is the resident alveolar macrophage. Its action: It senses the massive tissue damage from that initial insult. Its weapons? It rapidly releases massive quantities of TNF, IL-1 and crucially interleukin 8. Never forget interleukin 8. It is the ultimate chemical siren. Its sole job is to summon the riot police to the lungs. That brings us to step 2 and 3. The riot police and friendly fire. The arrival happens because interleukin 8 summons millions of neutrophils. They undergo diapedesis and swarm the site. But here's the tragedy, the friendly fire. These neutrophils degranulate in the total absence of bacteria. They recklessly unleash their weapons, reactive oxygen species, elastases and proteases. The result is catastrophic membrane damage. The delicate basement membrane is completely liquefied. Now the barrier is broken, leading to step 4, the flood and the plaster. The flood occurs because the shredded capillary barrier allows plasma proteins and fibrinogen to pour into the airspace. Simultaneously, we get necrosis. Those type 1 and type 2 pneumocytes die, completely halting surfactant production. Finally, the plaster forms. The leaked fibrin mixes with necrotic cell debris to create the hallmark of DAD, hyaline membranes. This waxy eosinophilic layer coats the ruined alveolar wall. Now let's track this timeline under the microscope through the 3 phases of DAD. Phase 1 is the acute or exudative phase from day 0 to 7. On gross anatomy, the lungs are heavy, dark red, boggy and airless. The microscopic hallmark is those eosinophilic glassy hyaline membranes with septae widened by edema. If the examiner asks, the buzzword is fibrin-rich edema mixed with necrotic epithelial debris. Moving to phase 2, the proliferative phase from 1 to 3 weeks. This is the counter-attack. Surviving stem cells, remember our type 2 pneumocyte caretakers, undergo frantic hyperplasia to reline the stripped alveolar walls. Simultaneously, fibroblasts begin migrating into the exudate to attempt repair. Phase 3 is the fibrotic phase, occurring after 3 weeks. This is the scar. If the fibrin exudate is not cleared, it gets organized into dense interstitial collagen. The result is permanent obliteration of the alveolar architecture, leaving us with a honeycomb lung. Let's bring this back to the patient. Clinical integration. Why is it lethal? The problem is that these hyaline membranes act as an impenetrable wall against oxygen diffusion. That is why a patient's 100% oxygen face mask failed. The solution is intubation with PEEP, or positive end expiratory pressure. We have to mechanically force those alveoli open against massive surface tension. But follow the rule. You must use a strict low tidal volumes to prevent overstretching and shattering the few healthy alveoli that are left. Before we finish, here's my exam cheat code. Beware of the hyaline trap. The examiners will test your ability to differentiate adult ARDS from neonatal RDS. In adult ARDS, the trigger is sepsis, trauma, or pancreatitis leading to neutrophil-mediated destruction in an injured lung. In neonatal RDS, it is a premature infant suffering from primary surfactant deficiency in an immature lung. Both result in hyaline membranes. They share the exact same histology under the microscope, but they have entirely different molecular triggers. Do not let the word hyaline trick you. Let's lock it in with our Module 1 summary. We covered the cells, type 1 for gas exchange and type 2 for surfactant and regeneration. We mastered atelectasis, resorption pulls the trachea, compression pushes it away, and contraction leaves a permanent scar. We reviewed sequestration, extralobar in infants with their own pleura, intralobar in adults sharing the pleura. And just now we conquered ARDS and DAD, driven by macrophages releasing interleukin 8, leading to neutrophil friendly fire and those deadly pink hyaline membranes. Up next, we are moving to part 2, the airway trap, where we will cover COPD, emphysema, chronic bronchitis and asthma. Welcome back to Conquer Pathology with Dr. P. Today we are launching into Module 2, Obstructive Lung Diseases. Today's session is titled The Airway Trap. We are going to be mastering emphysema and laying down the foundation for the entire obstructive paradigm. Let's get into it. To understand obstructive lung disease, you have to understand the core problem: getting air out. The problem isn't getting air into the lungs. It is the structural narrowing or the loss of elastic recoil that prevents air from getting out. Look at the graphs on your screen. On the left, we have normal airflow where volume peaks rapidly, but on the right, look at that obstructive pattern curve. It is sluggish, flattened, and takes much longer. This brings us to the golden diagnostic hallmark of obstructive diseases, an FEV1 to FVC ratio of less than 0.7 or 70%. When you see this pattern, you need to think of what I call the four villains: emphysema, chronic bronchitis, asthma, and bronchiectasis. Let's meet our first villain with this case vignette. Enter the pink puffer. Take a look at his profile. Age and history: a 66-year-old male with a massive 45-pack year smoking history. His vitals: his skin is pink, meaning there is no cyanosis, but you can see visible muscle wasting. His posture: he is sitting in a classic tripod position, leaning forward, and he has a distinct barrel chest. His breathing: he is performing a slow exhalation via pursed lips. I want you to keep this question in mind as we go through the pathology. Why is this man fighting so hard just to empty his lungs? To answer that, we'll look at the pathological definition of emphysema. It is a very specific equation. Enlargement of distal air spaces plus the destruction of alveolar walls equals emphysema. Compare the normal alveoli on the left of the slide, which looks a tight, healthy bunch of grapes, to the emphysema on the right, where the walls are destroyed, creating large, useless cavities. But pay close attention to this absolute rule at the bottom. This happens without significant fibrosis. If fibrosis is present, you are dealing with a restrictive or mixed pattern, not pure emphysema. So what is destroying those walls? It all comes down to a protease versus anti-protease imbalance. Look at the scales on your screen. On the left, we have the attackers, specifically neutrophil elastase. It constantly attempts to degrade the lung's elastic network and is secreted by inflammatory cells during a normal immune response. On the right, we have the shield. This is alpha-1 antitrypsin or alpha-1 AT. It is synthesized in the liver and acts as the primary shield neutralizing elastase. It protects our lung tissue from enzymatic damage. In a healthy person, lung elasticity is maintained by this delicate continuous molecular truce. But what happens when you introduce a 45-pack year smoking habit? You get the dual strike of cigarette smoke. Strike 1 is a massive elastase release. The smoke acts as an irritant that summons millions of angry neutrophils that carpet bomb the alveoli. Strike 2 means the shield is neutralized. The oxidative stress from the smoke directly oxidizes the crucial methionine residue on alpha-1 AT, rendering it completely useless. The result? The elastin network is eaten alive. The alveoli collapse into giant floppy sacs. To understand where this destruction happens, we have to map out the battlefield. The pulmonary sinus. Robbins classifies emphysema strictly by where inside this functional respiratory unit the destruction begins. The airway flows in this order. First, the terminal bronchiole. Next, the respiratory bronchiole. Then the alveolar duct, and finally the alveolar sac. Remember, the sinus itself begins after the terminal bronchiole, starting with the respiratory bronchiole. Now let's break down how this destruction manifests in our anatomical subtypes matrix. We have 4 main subtypes to learn. First, centri-acinar. The affected area is the proximal sinus, specifically the respiratory bronchiole. The lobar distribution is mostly in the upper lobes or apical segments. The clinical target? Heavy smokers, representing over 95% of cases. Second, pan-acinar. The entire sinus is affected uniformly. This predominantly hits the lower lobes or the bases of the lung, and its clinical target is patients with alpha-1 AT deficiency, specifically the PIZ mutation. Distal acinar. This affects the distal sinus along the subpleural margins. It is distributed adjacent to the pleura and septae. The clinical target is young adults who are at high risk for bullae. And lastly, irregular. This features irregular focal scars with variable distribution. Clinically, it is mostly asymptomatic and often seen around heel tuberculosis scars. Let's look at the 2 heavyweights under the microscope and on gross pathology. In image A, we have centri-acinar, also known as smoker's lung. You can see the destruction is localized to the proximal acinus. Note the heavy upper lobe involvement, smoke rises, and so does the damage. In image B, we have panacinar, the genetic lung. We see uniform destruction from the respiratory bronchiole all the way to the terminal blind alveoli. Note the lower lobe predominance here. This brings us to a massive exam favorite, the high yield trap or the alpha-1 paradox. Imagine a 32-year-old non-smoker who presents with dyspnea and liver cirrhosis. How do these connect? Look at the endoplasmic reticulum diagram. We have a missing shield. Step 1. The mutant PIS protein misfolds. Step 2. That misfolded protein gets trapped inside the liver's endoplasmic reticulum, which causes liver cirrhosis. Step 3. Because it is trapped in the liver, the lungs are starved of their protective shield, which results in panacinar emphysema. The critical takeaway here is, the liver isn't damaged by elastase, it's damaged by the accumulation of the misfolded shield itself. Moving on to our third subtype, the ticking time bomb or distal acinar emphysema. The typical clinical target here is tall, thin, young males. It begins with subpleural alveolar destruction, leading to the formation of giant air pockets called bullae, which are anything greater than 1 cm. You can see this subpleural bullae formation clearly on the chest CT. Then a sudden spike in intrathoracic pressure, like coughing or lifting heavy weights, causes a bulla rupture. Air rushes into the pleural cavity, resulting in a spontaneous pneumothorax, which you can see on the chest X-ray. To make sure you never confuse the two heavyweights on test day, here is Dr. P's memorization matrix. Just remember the letter C and the letter P. For C, centri acinar is caused by cigarettes and affects the crown of the lung, meaning the upper lobes. For P, panacinar is caused by the protease shield missing, that's alpha-1 and affects the pedestal of the lung, meaning the lower lobes. Let's close today's session by answering the question from our very first vignette. Why was our pink puffer breathing through pursed lips? This is the physiological synthesis, the pursed lip lifeline. The core problem is that elastase snaps away the elastin network. Because of this, the small airways lose their radial traction. Look at diagram A. During a forced exhalation, those airways collapse shut, trapping massive amounts of air inside the lungs. The solution is diagram B, pursed lip breathing. By exhaling against tightly pursed lips, the patient artificially creates high back pressure known as autogenous PEEP inside the airways. This back pressure literally stents the floppy bronchioles open, allowing the trapped air to escape. It is a genius physiological survival mechanism. That wraps up our mastery of emphysema. Next, we are looking at the clinical pathology of chronic bronchitis. We are going to specifically break down the phenotype known as the blue bloater. Let's get right into it. Let's start by looking at our patient profile. We have a 50-year-old male. He is a bus driver and his BMI categorizes him as obese. On physical exam, you can see profound cyanosis and pitting edema on his legs. Look at his chief complaint. Doc, every morning for the last 3 years from November right through the February, I cough up half a cup thick yellowish green phlegm. When we run an arterial blood gas analysis, the numbers are alarming. His PaO2 is 52, meaning severe hypoxemia. His PaCO2 is 58, meaning severe hypercapnia. So what is happening to his airways? To understand that, we need to compare our definitions. As we discussed previously, emphysema is defined by morphology, specifically airspace enlargement. However, chronic bronchitis is defined purely by clinical criteria. This brings us to Dr. P's pathology rule. You must lock this in. Chronic bronchitis is a persistent productive cough for at least 3 consecutive months in at least 2 consecutive years, in the absence of any other identifiable cause. Notice the calendar on screen, hitting exactly those winter months year after year. Let's look at the pathogenesis. The primary trigger here is chronic cigarette smoke or industrial smog bombardment. When this bombardment hits the large airways like the trachea and bronchi, we see hypertrophy of the submucosal mucus glands. When it hits the small airways, the bronchioles, we see goblet cell metaplasia. The cellular infiltrate driving this inflammation consists of CD8 plus T cells, macrophages, and neutrophils. The ultimate consequence? The airways become physically plugged. Air cannot get in and air cannot get out. To quantify this under the microscope, we use the Reed index computation. The Reed index is equal to the thickness of the submucosal mucous glands divided by the distance between the epithelial basement membrane and the cartilage perichondrium. Look at the histopathology slide. It is measurement B divided by measurement A. Here are your diagnostic thresholds. Normal is less than 0.4. In chronic bronchitis, it is greater than 0.4, often reaching 0.6 or 0.7. Also, as a side note, the epithelium also shows a loss of ciliated cells and squamous metaplasia. Now for a high-yield exam cheat code. Why are they blue? Let's track the sequence. First, massive mucus plugs physically block the airways. This severe airway obstruction causes oxygen levels to crash, meaning the PaO2 drops. This hypoxemia triggers the kidneys to release erythropoietin or EPO. That EPO release causes secondary polycythemia, which is an excess red blood cell production. Finally, that deoxygenated thick blood results in profound cyanosis, giving a bluish tint to the lips and nail beds. Our next exam cheat code: why are they bloated? Step 1. The chronic hypoxia triggers generalized pulmonary vasoconstriction. Step 2. This constriction spikes the pulmonary artery pressure, causing pulmonary hypertension. Step 3. The right ventricle fails against this massive resistance, leading to right-sided heart failure, also known as cor pulmonale. Step 4. Venous blood backs up into the systemic circulation. The resulting symptoms of this backup are hepatomegaly, jugular venous distension, and massive peripheral pitting edema. When you look at chronic bronchitis submucosal glands, chronic bronchitis is essentially a mucosal swamp. It is wet, thick, full of green sludge, and absolutely zero fresh air is allowed to enter the premises. Let's bring this all together with the master differential. You must know the differences between emphysema, the pink puffer, and chronic bronchitis, the blue bloater. Primary lesion: emphysema affects the sinus with alveolar destruction. Chronic bronchitis affects the bronchi and bronchioles with mucus. Dyspnea: severe and early onset in emphysema, mild and late onset in chronic bronchitis. Cough and sputum: absent or scanty in emphysema, early, copious and purulent in chronic bronchitis. Cyanosis: absent in emphysema because it maintains oxygenation, prominent in chronic bronchitis due to severe hypoxemia. Cor pulmonale: rare and terminal in emphysema, common and early in chronic bronchitis. Elastic recoil: severely decreased in emphysema, normal in chronic bronchitis. Let's lock in our final review. The diagnosis is purely clinical: a productive cough for 3 or more consecutive months in 2 or more consecutive years, and the morphology is defined by Reed index greater than 0.4, which is driven by submucosal gland hypertrophy and goblet cell metaplasia. The hemodynamics to remember: hypoxia triggers vasoconstriction leading to cor pulmonale. This is exactly why a patient presents blue and bloated. Next, we are diving into concept 3 of our masterclass, bronchial asthma. Specifically, we are going to master the Th2 axis and the pathogenesis of atopic asthma. This is very high yield topic for understanding both the clinical presentation and the underlying cellular mechanisms of this obstructive lung disease. Let's get right into the presentation. Let's start by looking at case vignette 2.3, which I call the springtime panic. The patient: we have a 10-year-old boy who arrives in the ER on a breezy, pollen-filled April morning. The presentation: he is gasping for air, clutching his chest, and speaking only in single-word sentences. His terrified mother is at his bedside. The exam: on auscultation, loud, high-pitched expiratory wheezing is heard across all lung wheels. A review of his past medical history reveals severe childhood atopic dermatitis or eczema, as well as allergic rhinitis. Intervention: an inhaled albuterol nebulizer is administered. His breathing dramatically clears within just 15 minutes. Now let's connect the dots by deconstructing the clinical clues we just saw. First, the pollen and the April morning point directly to an environmental allergen trigger. Next, his history of eczema plus allergic rhinitis combined with his asthma attack completes what we call the atopic triad. The physical finding of expiratory wheezing is the clinical hallmark of airway obstruction in the small airways. Finally, the fact that this breathing clears with albuterol in 15 minutes confirms the presence of reversible bronchoconstriction. With that clinical picture in mind, let's look at defining the disease state. Asthma is defined as a chronic inflammatory disorder of the airways resulting in episodic wheezing and dyspnea. This disease rests on three fundamental pillars. Pillar 1 is chronic inflammation. This is the underlying fire. It is always there, smoldering in the background. Pillar 2 is reversible bronchoconstriction. This is the acute event, the sudden narrowing of the airways during an attack. Pillar 3 is airway hyperresponsiveness. This acts as the twitchy trigger to various stimuli that sets off the acute event. Asthma is not a single disease, it has multiple triggers. Let's review the etiology spectrum. First, we have non-atopic asthma, which is often viral induced and not linked to typical allergies. Second is atopic or allergic asthma. This represents more than 70% of all cases and is driven entirely by immune sensitization. This is the primary focus of today's lecture. Third one is drug-induced asthma, classic examples being aspirin-exacerbated respiratory disease. And fourth is occupational asthma, which is triggered by exposure to fumes, dusts, and industrial chemicals in the workplace. Let's zoom in on that majority group and look at the pathogenesis of the Th2 atopic axis. How does this happen at a cellular level? It happens in 4 steps. Step 1, the trigger. It begins with allergen exposure such as the spring pollen in our patient's case. Step 2, the axis. That allergen causes the activation of the Th2 immune axis. Step 3, the mechanism. This activation drives a classic type 1 hypersensitivity reaction. Step 4, the result. This hypersensitivity leads to massive IgE production, which binds to and causes mast cell degranulation, ultimately resulting in acute bronchoconstriction. Let's bring it all together for the full picture. Connected pathology. The history. Our patient had atopic dermatitis and rhinitis, which equals a pre-existing Th2 dominance. The trigger. The spring pollen equals type 1 hypersensitivity cross-linking. The crisis. The resulting mast cell release equals acute airway hyperresponsiveness and wheezing. The rescue. The inhaled albuterol acts directly to reverse that bronchoconstriction. That wraps up our session on the Th2 axis and atopic asthma. Next, we are diving straight into what I call the rotten highway, covering the clinical foundations of bronchiectasis and Cartagena syndrome. Let's jump right into a clinical scenario. Let's look at case vignette 2.4 to see our initial presentation. We have a 24-year-old male whose chief complaint is a chronic cough. His presentation is striking. Upon waking, he produces cupfuls of intensely foul-smelling purulent sputum. On physical exam, we note severe digital clubbing, and upon auscultation, his heart sounds are loudest on the right side of the sternum. Keep this question in mind as our diagnostic target for today's lecture. What underlying genetic defect does this patient harbor? Moving to radiology, we look for the classic signet ring sign. Notice the abnormal extension here on this scan. You can see how these dilated airways extend all the way out to the lung periphery. The visual ring is formed by a markedly dilated airway sitting right next to its accompanying pulmonary artery. So what exactly is bronchiectasis? By definition, it is the permanent abnormal dilation of the bronchi and bronchioles. The primary catalyst for this is the destruction of smooth muscle along with the destruction of the supporting elastic tissue. This entire destructive process is driven by chronic necrotizing infections. To understand this better, let's compare the pattern of destruction. In the pathology of emphysema, the target level is the distal alveoli, and the primary result is the loss of gas exchange surface area. However, in the pathology of bronchiectasis, the target level shifts to the structural walls of the medium to large bronchi. The primary result here is permanent airway dilation and structural collapse. This brings us to the engine of destruction known as Cole's vicious cycle. It is a continuous loop. It begins with an obstruction which leads directly to impaired clearance. Because clearance is impaired, a severe infection takes hold, resulting in wall necrosis. That necrosis causes the permanent dilation we know as bronchiectasis, which only creates further obstruction, starting the cycle all over again. What actually sets off this cycle? First, severe infections. These include necrotizing pneumonias from Staph aureus, Klebsiella or Pseudomonas, as well as childhood measles and whooping cough. Next is bronchial obstruction, which can be caused by inhaled foreign bodies or hilar tumor compression. We also see it triggered in cystic fibrosis, where defective CFTR chloride channels lead to dehydrated rock-hard mucus choking the airways. Finally, ciliary dysfunction, specifically primary ciliary dyskinesia or Cartagena syndrome, can initiate the cycle. Let's examine the gross pathology of this rotten highway. These airways can be dilated up to 4 times their normal size. The diagnostic key to remember is that normal airways taper down like tree branches and eventually disappear. Bronchiectatic airways do not. In fact, these damaged airways can be followed directly out to the pleural surface. Now, what happens under the microscope? There are 3 main things to look for. Number 1, you will see intense acute and chronic inflammation. Number 2, there is complete ulceration of the mucosal lining. And number 3, you will spot areas of squamous metaplasia, which is an adaptive tissue change in response to the damage. Let's return to solving vignette 2.4 from the beginning of this lecture. Remember the hard sounds on the right side? That indicates situs inversus. The foul sputum combined with HRCT signet rings points directly to bronchiectasis. Together, this classic triad implication tells us there is chronic sinusitis as well. When you combine situs inversus, bronchiectasis and chronic sinusitis, the diagnosis is Cartagena syndrome. Let's break down the genetic defect behind Cartagena syndrome. It is an autosomal recessive condition. The primary mechanism is immotile cilia across all mucosal surfaces, which is caused by a specific defect in the outer dinine arm. The embryologic result of this defect is a failure of left-right rotational flow during development, which leads to situs inversus. The pulmonary result is a failure to mechanically clear mucus, which ultimately leads to bronchiectasis and sinusitis. Let's wrap up with a high-yield review to fully conquer this topic. Core definition: bronchiectasis is the permanent dilation due to the destruction of smooth muscle and elastic tissue in medium and large bronchi. Key mechanism: it is driven by Cole's vicious cycle, a continuous loop of obstruction and infection. Radiology: look for the signet ring sign, where the airway is visibly more dilated than its accompanying artery. Gross pathology: the dilated airways fail to taper and extend directly to the pleural surface. Cartagena syndrome: remember the triad of situs inversus, bronchiectasis and sinusitis. It is caused by an autosomal recessive defect in the outer dinine arm. Welcome to Module 3 of Conquer Pathology with Dr. P. Today we are tackling the stiff lung. We will be covering restrictive and interstitial lung diseases or ILDs. If you are following the syllabus, this is mapping to PA 13.3 and PA 13.5, which is essential for your MBBS, NEET-PG and USMLE preparation. Let's get started. First, let's look at the mechanics of restriction. Think of a normal lung as the sponge. It has a 0.5 micrometer alveolar interstitium that is highly compliant and easy to expand. Now contrast that with the concrete seen in restrictive diseases. The lung is infiltrated by dense collagen, resulting in a severe loss of compliance. Because of this, the patient can exhale effortlessly but cannot stretch the lung to get air in. Moving to spirometry in the restrictive paradigm, here's your golden rule. The FEV1 to FVC ratio will be greater than or equal to 0.8, meaning 80% or higher. Why? Because the forced vital capacity or FVC plummets, the lung simply cannot stretch. Meanwhile, the forced expiratory volume drops less. This happens because the stiff fibrotic parenchyma pulls radially outward, keeping the airways open. Let's apply this to our case, the Velcro lung. Here's our clinical data. Our patient profile is a 68-year-old male, a retired banker with low smoking history and no occupational dust exposure. His presentation is a 2-year history of progressive, relentless shortness of breath plus a dry, hacking cough. The imaging on his HRCT shows dense subpleural and basilar fibrosis along with honeycomb cysts. On the auscultation recording, we hear fine, dry, inspiratory crackles sounding exactly like a strip of Velcro being ripped open. Our diagnostic question is, what is driving his lungs to turn into stone? To answer that, we must understand that idiopathic pulmonary fibrosis is not inflammation. The myth is that IPF is a chronic inflammatory disease. The clinical result of this myth is that giving immunosuppressive steroids kills these patients faster. The reality is that IPF is an aberrant wound healing process. It is driven by repetitive epithelial injury in a genetically susceptible host, and this occurs completely independent of the inflammatory cascade. Let's walk through this aberrant wound healing cascade. It starts with genetic susceptibility, specifically mutations in TERT or TERC causing premature telomere shortening and aging, or a MUC5B gain of function mutation causing mucociliary dysfunction. Next comes microinjury. Unknown environmental toxins or acid microaspiration cause continuous type 1 pneumocyte loss. This leads to cellular senescence. The type 2 pneumocytes, which act as stem cells, fail to regenerate the lining. They panic, and this panic results in hypersecretion, which is a massive release of pro-fibrotic cytokines. The most important of these cytokines is TGF-beta, the ultimate biological contractor. First is the summons. The panicking senescent type 2 pneumocytes secrete massive amounts of transforming growth factor beta or TGF-beta. Next is the command. TGF-beta summons myofibroblasts and commands rapid proliferation. Finally, the result. Unchecked type 1 and type 3 collagen deposition. The normal alveolar architecture is permanently obliterated. When we look at the biopsy, we see a pattern called usual interstitial pneumonia or UIP. You must look for two things. First, spatial heterogeneity. The disease is patchy. You will see normal air-filled lungs sitting directly adjacent to dense acellular pink scar tissue featuring a subpleural preference. Second, temporal heterogeneity. The scars are at different evolutionary stages. Old dense collagen sits immediately next to early active proliferating clusters. This brings us to the diagnostic slam dunk leading to end-stage collapse. First, we'll look for fibroblastic foci. These are active clusters of proliferating myofibroblasts. Finding this is the diagnostic slam dunk for UIP. Eventually, this leads to honeycomb lung. The collapsed alveoli dilate into cystic spaces lined by hyperplastic cuboidal epithelium. This represents the architectural end stage of the disease. Now for Dr. P's exam cheat codes. Let's contrast UIP with NSIP. Think of UIP as unpredictable interstitial patches. It is patchy and heterogeneous. Fibroblastic foci are present, and it has a deadly prognosis. On the other hand, think of NSIP as no spatial irregularity pattern. It is uniform and homogeneous. There are no fibroblastic foci, and it carries a better prognosis. Also, beware of this NEET-PG trap. Why the Velcro crackles? Well, the fibrotic walls snap shut on exhalation. Then, on deep inhalation, the sudden explosive mechanical snapping open of thousands of rigid airways creates that crisp crackle. Moving to pharmacology integration, we are confiscating the cement mixer. First is pirfenidone, which directly inhibits TGF-beta synthesis. Second is nintedanib, a tyrosine kinase inhibitor targeting PDGF, FGF and VEGF receptors. Regarding TGF-beta in IPF, can we fix it? No, but we can bury it in concrete. Remember, with these drugs, you aren't curing the scar, you are just slowing Bob the Builder down. Let's wrap up with the stiff lung bottom line. Number 1, physics. The FEV1 to FVC ratio is greater than or equal to 0.8. This high or normal ratio is driven by the severe loss of compliance and radial traction. Wound healing disorder involving senescent stem cells which is entirely separate from inflammation. Number 3, pathogenesis. It flows from genetics like TERT and MUC5B to epithelial microinjury leading to TGF-beta overproduction. And number 4, Pathology. The UIP biopsy requires both spatial and temporal heterogeneity, and finding fibroblastic foci is diagnostic. That covers the restrictive paradigm. Next, we are diving into the treatable siblings of interstitial lung diseases, NSIP and COP. If you are preparing for your exams, pay close attention, because today is all about mastering interstitial lung disease for the exams. Let's jump right in. We will start with case 3.2, which I call the hopeful biopsy. Let's look at the clinical picture. Our demographics show a 44-year-old female. Her history is significant for systemic sclerosis, also known as scleroderma, and her chief presentation is progressive dyspnea. But here is the critical warning sign on her imaging. There is no subpleural honeycombing. Moving to the pathologist's reveal under the microscope, we see that the interstitial inflammation and fibrosis are completely uniform. The affected areas are the exact same age and there are zero fibroblastic foci. So what is this entity and why is the patient so relieved to hear this diagnosis? The answer is NSIP, the polite sibling. NSIP stands for non-specific interstitial pneumonia. It is the well-behaved, treatable counterpart to UIP. We typically see this associated with connective tissue diseases such as scleroderma or rheumatoid arthritis. It can also have idiopathic origins, meaning there is an unknown cause, but it has the exact identical presentation. Let's break down the morphology into two patterns. First is cellular NSIP. Here the interstitium is packed with chronic inflammatory cells, specifically lymphocytes and plasma cells, and there is very little collagen. Second is fibrosing NSIP, which is characterized by diffuse uniform interstitial fibrosis. Regardless of the pattern, the prognosis is excellent because it responds beautifully to steroids. Now here is the absolute key for your exams. Temporal uniformity. Think of the clocks all starting at exactly 0000. Everything happens at the same time uniformly. Unlike UIP, there is no patchwork, and there are no differing ages of lesions. Next, enter cryptogenic organizing pneumonia or COP. Historically, you might see this referred to as BOOP, which stands for bronchiolitis obliterans organizing pneumonia. The classic clinical vignette involves a patient who recovers from a viral pneumonia or toxin exposure, but their symptoms do not resolve. They present with a lingering cough and dyspnea. Ultimately, it is the biopsy that reveals the true pathology. In COP, the alveolar architecture is preserved, but the space is plugged. Your diagnostic key here is meson bodies. As you can see on the slide, these are round polypoid plugs of loose organizing connective tissue sitting directly inside the alveolar spaces and bronchioles. It's time for Dr. P's exam cheat code. Let's log this in by comparing our three entities. First, UIP, the bad sibling. The location of fibrosis is in the wall, the pattern is messy and patchwork, and the key feature is fibroblastic foci. Second, NSIP, the polite sibling. The fibrosis is also in the wall, but the pattern is neat and uniform with zero foci. Finally, COP, the cousin. The fibrosis is inside the space acting like loose corks, and the key feature you must look for are meson bodies. Let's finish up with a step 1 pearl, the miraculous recovery using oral corticosteroids. On exam day, if your trigger is a vignette that shows a lung biopsy with meson bodies, your immediate action must be to check the treatment options for oral corticosteroids. The clinical result is that these patients experience an almost miraculous overnight recovery. Next in this module, we are tackling the pneumoconiosis, which I like to call the occupational killers. Our clinical focus today is on occupational lung diseases characterized by fibrosis due to inhaled dust. We will be covering 4 main culprits: asbestosis, coal worker disease with silicosis and berylliosis. Let's start with case 3.3, the shipyard ghost. We have a 72-year-old male who is a retired naval shipyard worker presenting with severe dyspnea and weight loss. On imaging, the clinical clues reveal diaphragmatic pleural plaques and dense interstitial basal fibrosis. The mystery we need to solve is, what specific dust did this man inhale 40 years ago? To understand these diseases, we must first learn the 1 to 5 micrometer rule. Particles greater than 5 micrometers are safely trapped in mucus and coughed out. Particles smaller than 0.5 micrometers act like a gas, they float in and float right back out. but particles between 1 to 5 micrometers enter the kill zone. These particles completely bypass the mucociliary escalator and impact directly into the terminal alveoli. What happens when they reach the alveoli? It leads to the pathogenesis we call the macrophage massacre. Step 1 is phagocytosis, where the alveolar macrophage consumes the 1 to 5 micrometer inorganic mineral. Step 2 is mechanical failure, because the indigestible mineral actually pierces the macrophage phagolysosome. Step 3 is cell death. This macrophage death activates the NLRP3 inflammasome. Finally, step 4 is fibrogenesis, where the dying macrophages releases interleukin-1 and fibronectin, resulting in permanent scar formation. Let's look at our suspects board to compare these diseases. First is coal workers' pneumoconiosis, seen in coal miners and targeting the upper lobes. Pathologically, it progresses from anthracosis to coal macules and finally to progressive massive fibrosis or PMF, and can be associated with Kaplan syndrome. Next is silicosis, common in sandblasters, foundry and stone workers. It also targets the upper lobes, featuring whorled collagen nodules and axial calcifications of the hilar nodes, and is the number 1 occupational chronic disease. Third is asbestosis, affecting shipyard workers and roofers. Unlike the others, it targets the lower lobes and involves serpentine versus amphibole fibers, ferruginous bodies, and pleural plaques. Finally, berylliosis is found in aerospace and nuclear workers, targets the upper lobes, and features a type 4 hypersensitivity reaction with non-caseating sarcoid-like granulomas. Let's talk about the location trap on exams. Remember this rule: coal and silica hit the roof, meaning they target the upper lobes, but here is Dr. P's cheat code, and asbestos falls to the base. It targets the basement, meaning asbestos hits the lower lobes. Now for a premium clinical dossier deep dive on the silica strike. The morphology reveals hard pale nodules made of concentrically whorled collagen fibers wrapping around an amorphous core. The fatal flaw in silicosis is that crystalline quartz silica permanently cripples the macrophage phagolysosomes. This leads to a massive high yield rule for your exams. If a patient has a fever and silicosis, you must assume tuberculosis until proven otherwise. Next, let's look at the two fibers of asbestos. The first is serpentine or chrysotile, which has a curly geometry. This causes it to get caught in the upper airways, making it cleared easily by the body. The second is amphibole, which has straight and stiff geometry acting like aerodynamic darts. It plunges deep into the lower lung bases where macrophages get skewered. This brings us to the pathognomic feature, the ferruginous body. The process occurs when the macrophage attempts to coat the indestructible amphibole fiber in an iron protein mucopolysaccharide matrix. The result is the pathognomic asbestos body, also known as the ferruginous body. Your visual cue under the microscope is a microscopic golden brown wooden dumbbell shape which features translucent swollen ends. Beware of the malignancy trap. If you are asked what is the most common malignancy associated with asbestos, the immediate student instinct is to say mesothelioma, which is wrong. Mesothelioma is the most specific, but the clinical reality is that bronchogenic carcinoma or lung cancer is the right answer because it is the most common. Also keep the smoking multiplier in mind. Smoking combined with asbestos gives a 55 times synergistic risk. To do a quick pop culture reset, imagine the alveolar macrophage confidently attempting to digest, but the asbestos amphibole fiber replies, "You're just going to destroy yourself." The attempted digestion directly leads to a catastrophic localized macrophage explosion, which causes permanent fibrosis. Let's look at the case resolution for the shipyard ghost. Clue 1 solved. The shipyard worker history points to asbestos exposure. Clue 2 solved. The basal fibrosis and pleural plaques point to amphiboles in the lung bases. Clue 3 solved. A biopsy showing Prussian blue positive dumbbells indicates ferruginous bodies coated in iron. Therefore, the final diagnosis is asbestosis. We will wrap up with Dr. P's final prescription. Remember the 1 to 5 micrometer rule? It is the precise alveolar strike zone for occupational dust. For silica, it targets the roof, meaning upper lobes, features whorled nodules, and you must assume TB if the patient is feverish. For asbestos, it targets the basement, meaning lower lobes, features ferruginous bodies, and remember that bronchogenic carcinoma is more common than mesothelioma. Next, we are going to focus on the great mimickers, which are sarcoidosis and hypersensitivity pneumonitis. Looking at our diagram, you can see our primary targets: sarcoid granulomas and bilateral hilar lymphadenopathy, which is a classic hallmark of sarcoidosis. Let's begin with case vignette 3.4, which I like to call the multi-system enigma. Our patient profile is a 29-year-old female. Her chief complaint is a 3-week history of fatigue, blurry vision, and a dry cough. Let's look at the key findings. First, she has tender red nodules on her anterior shins known as erythema nodosum, which you can see here in figure 1. Next, her labs show an elevated serum ACE and hypercalcemia. Finally, looking at figure 2, her PA chest X-ray showing bilateral hilar lymphadenopathy with the blue outlines indicating those enlarged nodes. The reveal here is that a transbronchial biopsy reveals well-formed granulomas with zero central necrosis. Why does this happen? Let's walk through the pathogenesis cascade of this type 4 hypersensitivity. The initial trigger is an unknown airborne antigen. In step 1, antigen presenting cells or APCs show the trigger to CD4 positive T helper cells. Moving to step 2, those T cells differentiate into Th1 cells, releasing bursts of interferon gamma and interleukin 2. In step 3, the interferon gamma hyperactivates systemic monocytes. The ultimate result is that these monocytes transform into plump epithelioid macrophages, fusing into multinucleated giant cells to build tightly clustered non-caseating granulomas, meaning there is absolutely no cheesy dead necrosis. And that brings us to our diagnosis: sarcoidosis. Note that 90% of these patients present with lung or hilar lymph node involvement. The microscopic hallmark you must look for are tightly clustered multinucleated giant cells, and the crucial distinction to make on your exam is that there is no cheesy central necrosis, which is unlike what you would see in tuberculosis. Let's examine some high-yield microscopic inclusion bodies. First are Schaumann bodies. These are laminated, concentrically calcified basophilic protein structures. When you look at them, think of tree trunk cross sections. Second are asteroid bodies. These are star-shaped or stellate, intensely eosinophilic needle-like inclusions made of tangled intermediate filaments. Now here is Dr. P's caveat. Neither of these are strictly specific to sarcoidosis, as they can also be seen in TB or berylliosis, but on your exams, they are giant neon signposts for sarcoid. Let's lock in those points with Dr. P's exam cheat code on Lofgren syndrome. The rule is simple. If you see this specific triad, bilateral hilar lymphadenopathy plus erythema nodosum plus migratory polyarthralgias, that equals 100% sarcoidosis. Therefore, no biopsy is needed. If asked for the next step, do not choose performing a transbronchial biopsy. Instead, you are diagnosing clinically via Lofgren syndrome. Time for some vertical integration with the hypercalcemia enigma. Why did our sarcoidosis patient from the vignette have hypercalcemia? Number 1, the epithelioid macrophages inside the granulomas express their own autonomous 1-alpha hydroxylase enzyme. Number 2, this enzyme converts inactive vitamin D into active 1,25-dihydroxyvitamin D, which happens completely independent of parathyroid hormone feedback. Finally, number 3, the active vitamin drives massive calcium absorption from the gut right into the bloodstream. Let's switch our focus to the mimicker, hypersensitivity pneumonitis or HP. The disease profile is also known as the extrinsic allergic alveolitis. It is an immune-mediated lung disease caused by the intense, prolonged inhalation of organic occupational dusts. Variant 1 is farmer's lung, which is caused by inhaling thermophilic actinomycetes from moldy hay. Variant 2 is bird fancier's lung, caused by inhaling proteins from pigeon or parrot droppings. For HP pathogenesis and histology, the immunology is unique. It is a mixture of type 3, which is immune complex, and type 4, which is cell-mediated hypersensitivity. When we take a microscopic look at the histology, we see loosely formed, poorly defined non-caseating granulomas. The geographic hallmark of these granulomas is that they are characteristically centered strictly around the terminal bronchioles. To keep these straight on exam day, here's your diagnostic matrix comparing sarcoidosis versus hypersensitivity pneumonitis. Looking at the triggers, sarcoidosis has an unknown airborne antigen, while HP is triggered by organic occupational dusts. For the hypersensitivity type, sarcoidosis is a pure type 4, whereas HP is a mixed type 3 and 4. Looking at the granuloma style, sarcoidosis gives you tightly clustered, well-formed granulomas, but HP yields loosely formed, poorly defined ones. Lastly, there are key microlocations. Sarcoidosis granulomas are found along lymphatics and blood vessels, while HP granulomas are centered strictly around the terminal bronchioles. Let's tie the whole module together with the master synthesis. Restrictive lung diseases, Part 1. First, remember the restrictive hallmark, an FEV1 to FVC ratio greater than or equal to 0.8. Next, idiopathic pulmonary fibrosis or the UIP pattern is driven by TGF-beta, defined by spatial temporal heterogeneity, and its pathognomic feature is fibroblastic foci. Comparing NSIP versus COP, NSIP is uniform while COP plugs the air spaces with meson bodies. And remember, both are rapid steroid responders. Continuing to the master synthesis, restrictive lung diseases, Part 2. For the pneumoconiosis caused by 1 to 5 micrometer particles, remember that silica hits the upper lobes and carries an increased TB risk. Asbestos hits the lower lobe, has ferruginous bodies, and carries a high bronchogenic carcinoma risk. Finally, sarcoidosis. It is Th1 and interferon gamma driven. It causes non-caseating granulomas, and you must look for Schaumann and asteroid bodies and elevated ACE and hypercalcemia. And with that, here's our status update. Chapter 15 is officially 50% complete. Here are Dr. P's orders for you. Take a well-deserved hydration break and shake out those hand cramps. Up next, we will cover Module 4, the pulmonary plumbing, where we'll be untangling the hemodynamics of pulmonary embolism, pulmonary hypertension, and alveolar hemorrhage. Until then, keep grinding, keep dominating your question banks, and conquer pathology with Dr. P. Welcome back to Conquer Pathology with Dr. P. Today we are starting Module 4, which covers hemodynamics and vascular diseases. Our main topic today is the pulmonary plumbing, where we will untangle the details of pulmonary embolism, infarction, and the low pressure paradigm. Let's dive in. We begin by looking at the cardiovascular system, which produces the same output but at a fraction of the pressure. Let's look at the left ventricle. It pumps a volume of 5 liters per minute at a high pressure of 90 millimeters of mercury. Now compare that to the right ventricle. It also pumps a volume of 5 liters per minute but at a pressure of only 12 to 15 millimeters of mercury. This brings us to the paradigm. The right ventricle pumps the exact same blood volume as the muscular left ventricle but at a fraction of the pressure. So what is the mechanism behind this? How does the lung survive this massive flow? The answer is that the pulmonary vasculature is exceptionally thin-walled, highly distensible, and possesses massive reserve capacity to recruit closed capillaries when cardiac output spikes. Let's put this into context with case vignette 4.1. The 48-hour post-op ambush. Our patient profile is a 70-year-old male who is 2 days post-op from a total right hip arthroplasty. Looking at the event timeline, Step 1. He ambulated to the bathroom. Step 2. He experienced sudden chest pain. Step 3. Gasping for air. Step 4. Collapse. And Step 5. A PEA cardiac arrest. As you can see on the bedside echo, there is massive RV dilation and it is poorly contracting. Our bedside echo findings confirm a massively dilated and hypokinetic right ventricle. This leaves us with a critical diagnostic query. What silent killer just traveled from his calf to his lung? To answer that, we must understand that 95% of pulmonary emboli originate from lower leg DVTs, specifically originating in the popliteal, femoral, and iliac veins. They are dictated by Virchow's triad. Think of Virchow's triad as the lock to deep vein thrombosis. It has 3 components. First is stasis of blood flow, seen in situations like post-op bed rest or long-haul flights. Second is hypercoagulability, driven by factors like factor V-Leiden, active malignancy, or oral contraceptives. Third is endothelial injury caused by events like surgical trauma or orthopedic reaming. Let's trace this path from calf to catastrophe. This is the anatomical journey of the clot. Step 1.
the clot breaks free from the popliteal or femoral vein in the lower leg. Step 2, it shoots upward through the right channel of the inferior vena cava. Step 3, it enters the right atrium and passes into the right ventricle. Finally, step 4, it slams into the narrow bifurcation of the pulmonary artery. That impact point leads us to the bottleneck, the saddle embolus. The mechanism here is deadly simple. A massive long coiled TVT sails smoothly through wide venous channels until it hits the very first narrow bottleneck, which is the pulmonary arterial tree. By definition, a saddle embolus is an embolus that physically straddles the bifurcation of the main pulmonary artery, occluding both the right and the left branches simultaneously. Why does a massive PE kill instantly? It is due to the dual catastrophe of a saddle embolus. Let's look at pathway 1, mechanical obstruction. Because the pulmonary artery is blocked, we get an empty left ventricle. Number 1, blood cannot reach the lungs. Number 2, left ventricular preload drops to 0. Number 3, cardiac output crashes. The result of this pathway is systemic hypotension and shock. Now let's look at pathway 2, neurohumoral vasoconstriction. The trapped platelets degranulate, vomiting out serotonin and thromboxane A2. This triggers intense brainless vasoconstriction of the patent pulmonary arteries. Because of this, the right ventricular afterload spikes. The result is acute cor pulmonale or right heart failure. Let's shift gears to the 10% rule. Why are pulmonary infarcts rare? This comes down to the dual blood supply protection mechanism. The rule is that only around 10% of pulmonary emboli cause true tissue infarction. Let's look at the anatomy of this dual blood supply. The lung is protected by a dual plumbing system. Even with a blocked pulmonary artery from an embolus, the lung receives systemic oxygen-rich backup directly from the bronchial arteries branching off the aorta, providing collateral flow. Therefore, the clinical requirement for true tissue necrosis to occur is that the patient almost always has compromised bronchial backup, for example, a pre-existing left-sided heart failure or underlying lung disease. If an infarct does occur, what does it look like? Looking at the anatomy of a pulmonary infarct on a gross pathology evidence board, we first notice the shape. It is wedge-shaped. The base of the lesion rests against the pleural surface and the apex points directly towards the occluded vessel at the hilum. Next is the color. It is hemorrhagic, meaning it is profoundly red. Why is it red? Because collateral blood from the bronchial arteries continues to seep into the necrotic tissue. The dead capillaries then leak red blood cells directly into the alveoli. Let's look at the microscopic pathology and clinical correlation of that red wedge. At the cellular level, the histology reveals coagulated necrosis of the alveolar walls, which are densely packed and stuffed with extravasated erythrocytes. Moving to the patient level, the clinical link is that over 48 hours, the overlying pleura develops fibrinous pleuritis. This explains why non-fatal PE patients present complaining of sharp localized pleuritic chest pain. It is time for Dr. P's exam cheat code, the forensic clot matrix. A common question for pathologists is, did the DVT kill them or did they die with it? Let's compare. For an antemortem thrombus, the defining feature is that lines of Zahn are present. The appearance shows distinct laminations of pale pink platelets and fibrin alternating with dark red erythrocytes. The mechanism is that this requires flowing blood to form. This means the DVT killed them. Conversely, a post-mortem clot has the feature of no lines of Zahn. The appearance is dark red and gelatinous, characterized as a uniform classic currant jelly or chicken fat appearance. The mechanism here is that it formed in stagnant blood after death. Let's wrap up with the pulmonary plumbing. Hemodynamics synthesized. Here's your Module 4 master summary. Number 1, the paradigm. It is a low pressure system. The right ventricle delicately pumps 5 liters per minute at 12 to 15 millimeters of mercury. Number 2, the source. 95% originate from lower leg DVTs dictated by the 3 elements of Virchow's triad. Number 3, the kill mechanism. It is a combination of mechanical shock due to zero LV preload paired with neurohumoral cor pulmonale caused by serotonin and thromboxane A2 vasoconstriction. Number 4, the infarct and proof. The infarct is wedge-shaped and red due to collateral seepage and it requires a compromised bronchial supply to form. And remember, the presence of lines of Zahn indicates it was antemortem. Continuing with Module 15, the lung, we are diving deep into the hemodynamic crisis. We will be completely unraveling the pathology of pulmonary hypertension. Let's get started. Let's introduce our clinical scenario for today with case vignette 4.2, the young woman's syncope. Looking at our pressure tracing, we note a diastolic of 25, a systolic greater than 55, and an MPAP of 34. Our patient is a 26-year-old woman with no past medical history. She presents with progressive exertional dyspnea and 2 recent episodes of fainting or syncope while climbing stairs. On physical exam, she has a loud, palpable P2 heart sound and a parasternal heave. A right heart catheterization reveals a resting mean pulmonary artery pressure or MPAP of 34 mm of mercury, but a completely normal pulmonary capillary wedge pressure. A critical piece of her family history is that her maternal aunt died of unexplained heart failure at age 30. Keep this question in mind: what gene is mutated in this young woman? First, let's start by defining the hemodynamic threat. By definition, pulmonary hypertension is an MPAP greater than or equal to 25 mm of mercury. To put that in perspective, normal resting pressure is less than or equal to 20 mm of mercury. So going back to our vignette, our 26-year-old patient presented with a resting MPAP of 34 mm of mercury. This places her definitively into the category of severe pulmonary hypertension. To figure out why she has this, we use the WHO classification diagnostic map, which divides the causes into 5 groups. Group 1 is pulmonary arterial hypertension or PAH. The causes here include idiopathic, familial, and the BMPR2 mutation. Group 2 is driven by left heart diseases with causes like mitral stenosis or left ventricular failure. Group 3 is driven by lung diseases with causes being COPD, idiopathic pulmonary fibrosis, obstructive sleep apnea, and chronic hypoxia. Group 4 is caused by chronic pulmonary embolism, specifically CTEPH, which stands for chronic thromboembolic pulmonary hypertension from unresolved thrombi. Finally, Group 5 is multifactorial, including causes like sarcoidosis and hematologic disorders. Let's look back at our patient for a moment, isolating the suspect to idiopathic or familial PAH. The callback clue from her history was that her maternal aunt died at age 30. This points us directly to the BMPR2 gene, which stands for bone morphogenetic protein receptor type 2. This mutation is found in up to 80% of familial cases, and it is also found in 20% of sporadic cases. The mechanism of this receptor is that it normally signals via the TGF-beta pathway. However, when you have inactivating mutations, they trigger the total collapse of vascular homeostasis. I want you to think of this mutation as the cut brake line. An intact BMPR2 acts as a molecular brake pedal on vascular smooth muscle and endothelial proliferation. As long as it is functioning, homeostasis is maintained. But when BMPR2 is mutated, the brake line is cut. Without those brakes, the endothelial and smooth muscle cell undergo brainless runaway proliferation. The proliferation causes a dangerous biochemical shift in the pulmonary vessels. On one hand, our key vasodilators, nitric oxide and prostacyclin, have decreased synthesis. This results in a severe loss of vascular relaxation. On the other hand, endothelin-1, which is a potent vasoconstrictor and mitogen, sees increased synthesis. This leads to uncontrolled constriction and cell growth. Let's look at the microscopic wreckage caused by this shift through the vascular remodeling pipeline. Step 1 is the normal structure, where we see thin walls and uninhibited blood flow. In step 2, we develop medial hypertrophy. We see a thickened smooth muscle layer in the small pulmonary arteries, which causes the lumen to narrow. Finally, in step 3, we see intimal thickening. This is a concentric fibrosis of the intima, creating a classic onion skin appearance that severely restricts blood flow. Ultimately, this process leads to the pathognomic hallmark of this disease, plexiform lesions. When pulmonary artery pressures reach catastrophic levels in Group 1 PAH, the endothelial cells proliferate into a tangled, chaotic tuft of multiple tiny capillary-like channels right inside the lumen of a small artery. As you can see comparing these images, a plexiform lesion in the lung is looking literally like a macroscope glomerulus inside the lung. To truly understand the hemodynamics here, imagine navigating the plexiform maze from the perspective of our RBC. Trying to push a RBC through a severe plexiform lesion is literally trying to navigate a matrix. The corridor is blocked, there are dead ends everywhere, the walls are closing in, and the right ventricle is back there blowing out its transmission trying to force you through. How do we treat this? We use the pharmacology target map for fixing the endothelium. Target 1 addresses endothelin 1 using bosentan or ambrisentan. These are endothelin 1 receptor antagonists acting as a shield and blocking the heavy vasoconstrictor. Target 2 targets nitric oxide using sildenafil or tadalafil. These are PDE5 inhibitors. They keep the cGMP high to enhance nitric oxide vasodilation. Target 3 addresses prostacyclin using epoprostenol or iloprost. These are synthetic prostacyclin analogs that directly replace lost PGI2 to push the balance down and promote vasodilation. Let's wrap this up with Dr. P's exam cheat codes. First, the core mnemonic to remember the gene. Think of BMPR2 as the brake mechanism for pulmonary remodeling 2. Next, watch out the exam trap regarding inheritance. It is autosomal dominant with incomplete penetrance. Also, beware of the classic demographic trap. On exam questions, always look for the young female with unexplained right heart failure and a family history. Which brings us to our final case resolution for vignette 4.2. The 26-year-old female has familial group 1 PAH due to BMPR2 mutation. Her syncope is due to right ventricular strain pushing against those plexiform lesions. Her treatment begins immediately with targeted endothelial therapy, utilizing drugs like bosentan combined with sildenafil. Next, we are looking at what I call the deadly duo: diffuse alveolar hemorrhage and Goodpasture syndrome. Let's get right into it. We will start with a clinical case. Here's a patient profile: a 22-year-old male who is a heavy smoker. His primary presentation is massive hemoptysis, meaning he is coughing up bright red blood, combined with severe fatigue. Let's look at his vitals and labs. His hemoglobin has plummeted to 7.2 grams per deciliter, indicating severe iron deficiency anemia. His urine analysis shows hematuria along with RBC casts. Finally, his serum creatinine is spiked at 3.4 mg per deciliter, pointing to acute renal failure. When we perform a biopsy to investigate, we use a direct immunofluorescence or DIF micrograph mount. This renal biopsy reveals smooth, linear, ribbon-like IgG deposition all along the glomerular basement membrane. So the key question for us to answer is, what autoantibody is attacking this young man? The answer is Goodpasture syndrome. This diagnosis requires a classic triad. First, massive hemoptysis. Second, rapidly progressive glomerulonephritis. And third, that smooth linear IgG immunofluorescence we just saw. From an immunological standpoint, remember that this is the prototype type 2 or cytotoxic hypersensitivity. But what is the actual target of this hypersensitivity? The target is found in exactly 2 places in the human body. It is specifically the non-collagenous or NC1 domain of the alpha-3 chain of type 4 collagen. You will find this specific molecular target exclusively in the glomerular basement membrane or GBM and the alveolar basement membrane. Let's look at how the destruction happens in the lungs, step by step, starting with complement protein C3b. Step 1 is bind. Circulating IgG autoantibodies attach directly to the alveolar capillaries. Step 2 is amplify. The classical complement cascade is activated, resulting in a massive C5a spike. Step 3 is destroy. Drawn by that spike, neutrophils rush in, chemically obliterating the delicate alveolar capillary barrier. Finally, step 4 is flood. The barrier breaks and the massive amounts of RBCs flood directly into the alveolar spaces. Once the bleeding stops, in comes the cleanup crew. The alveolar spaces are now flooded with fresh erythrocytes. To handle this, we see the arrival of hemosiderin-laden macrophages. These alveolar macrophages spend weeks digesting the carnage. As they process the RBCs, they eventually become permanently stuffed with iron. Now for a high-yield exam trap, the smoking trigger. You might be asked, why do some Goodpasture patients only get kidney failure without the lung hemorrhage? It comes down to the shield. The alpha-3 antigen in the lung is normally hidden deep inside the basement membrane, so antibodies simply cannot reach it. However, we have the trigger. Factors like heavy cigarette smoking, hydrocarbon solvents, or viral infections strip away that protective endothelial lining. As a result, the hidden antigen is suddenly exposed, directly leading to explosive fatal hematosis. This is exactly why our 22-year-old heavy smoker presented this way. Let's compare this with similar conditions using our diagnostic matrix. For Goodpasture syndrome, the immunological mechanism is a type 2 hypersensitivity. The renal immunofluorescence pattern shows linear IgG, and the key serology is a positive anti-GBM. For granulomatosis with polyangiitis, historically known as vaginous, the mechanism is a small vessel necrotizing vasculitis. The renal immunofluorescence pattern is posse-immune, meaning it is negative or blank. The key serology is positive C-ANCA or anti-PR3. Finally, for idiopathic pulmonary hemosiderosis, the mechanism is unknown, but it typically presents in young children with no renal disease. The renal immunofluorescence pattern is negative, and they have negative serologies, but the condition notably responds to steroids. Let's sum up this hemodynamics module. Drop the wrench, plumbing inspection is complete. Let's review what we have covered. For pulmonary embolism or PE, remember that 95% originate from lower leg DVTs. A saddle embolus causes acute right ventricular failure via serotonin and thromboxane vasoconstriction. Look for wedge-shaped red infarcts and antemortem lines of Zan. For pulmonary arterial hypertension or PAH, it is defined by an MPAP greater than or equal to 25 mm of mercury. Group 1 is linked to BMPRD mutations where endothelin spikes and nitric oxide drops, and the end-stage hallmark is plexiform lesions. And Goodpasture syndrome is driven by anti-alpha-3 type 4 collagen IgG causing hematosis and nephritis. Look for linear IgG ribbons on renal immunofluorescence and sputum containing hemosiderin-laden macrophages. You guys are absolute troopers. Over my 13 years of teaching, I know this is the point where mental fatigue usually sets in. So stretch your backs and take a deep breath. Next up is part 5, the invaders. We will be comparing lobar versus bronchopneumonia, discussing the atypical walkers, examining tuberculosis cavities, and identifying opportunistic ICU fungi. Until then, keep pushing forward, keep trusting your revision, and conquer pathology. Welcome back to Conquer Pathology with Dr. P. Today we are beginning Module 5, our clinical guide to typical bacterial pneumonias. We are examining pathogenesis, bacterial infiltration, focusing on the invaders that cause pulmonary infections. Our main target today is lobar pneumonia and the process of consolidation. Let's dive in. Before an infection can take hold, it must face the fortress defenses. Every day you have 10,000 liters of non-sterile air inhaled daily. Yet under normal conditions, there are 0 alveolar microbes. How? First, the nasal turbinates act as physical traps for macro debris. Next is the mucociliary escalator, which acts as a 24/7 luggage belt continually ejecting foreign invaders. If something gets past that, the cough reflex provides a 100 miles per hour ballistic expulsion. Finally, down in the alveoli we have the alveolar macrophages, the resident assassins providing silent elimination right on the floor tiles. But what happens during a failure? This is the breach, defining consolidation. When defenses fall, whether through intoxication, viral paralysis, or immunosuppression, bacteria multiply. Compare the normal state to the breach of consolidation. The normal alveolar airspace is swapped for an inflammatory exudate. This exact swap equals pneumonia. Let's look at case file 5.1, the rusty cough. Our patient profile is a 48-year-old male with a history of chronic alcoholism presenting after an exposure to freezing rain. Our timeline alert shows we are 48 hours post-exposure. His clinical presentation is severe. A temperature of 103 degrees Fahrenheit with violent rigors. His breathing is rapid and shallow. On exam, his percussion is strictly dull over the right lower chest and his fremitus is dramatically increased. Crucially, his sputum is thick and pathognomic rusty colored. Keep this question in mind. What organism breached the perimeter? Before identifying the bug, let's look at the macroscopic architecture and the two patterns of bacterial invasion. The first is lobar pneumonia, characterized by uniform lobar flooding. The second is bronchopneumonia, which presents as a patchy lobular scattering. Let's examine the mechanisms of invasion for these patterns. In lobar pneumonia, we see lateral spread via the pores of corn. The exudate flows laterally from alveolus to alveolus, ignoring segmental boundaries until it hits a pleural fissure brick wall. Conversely, in bronchopneumonia, we see terminal spillover from bronchial origins. The infection strictly originates in the bronchioles and spills over locally. It does not utilize the pores of Kohn. Let's lock this down with the two fronts, comparison matrix. Looking at geography, lobar pneumonia has a uniform consolidation of entire lobes, whereas bronchopneumonia has a patchy haphazard consolidation that is often bilateral or basilar. Looking at the mechanism, lobar is alveolar to alveolar via the pores of Kohn, while broncho is a bronchiolar spillover to local alveoli. Finally, the primary culprits for lobar, it's a Streptococcus pneumonia in more than 90% of cases, along with Klebsiella pneumoniae. For broncho, the culprits are Staph aureus, Haemophilus influenzae, and Pseudomonas aeruginosa. Now let's focus exclusively on the progression of lobar pneumonia in what I call the 4-day siege. Here is the histological timeline of lobar pneumonia. First is congestion on days 1 to 2. Second is red hepatization on days 2 to 4. Third is grey hepatization on days 4 to 6. And fourth is resolution from day 8 onward. Robbins dictates precise memorization of this sequence for your pathology exam. So let's break them down. We begin with stage 1, congestion, occurring days 1 to 2. The gross profile is a heavy, boggy, dark red and wet lung. When we do a microscopic recon, we see vascular engorgement where the capillaries dilate aggressively. This marks the initial breach. The intraalveolar fluid is rich in actively multiplying bacteria. The cellular status at this point is that very few neutrophils have arrived yet. This leads into stage 2, red hepatization on days 2 to 4. The gross profile here is firm and airless. It literally resembles a fresh red liver or hepar. Moving to our microscopic recon, we see the cavalry charge. Millions of neutrophils gallop across the capillary endothelium. This creates the flood. The alveoli are packed to the brim with neutrophils, fibrin strands, and leaked RBCs. Remember a vignette? This combination of leaked vascular blood plus purulent pus equals the clinical rusty sputum. Next is stage 3, grey hepatization, spanning days 4 to 6. The gross profile shifts as the lung turns dry, solid, and grey-brown. On microscopic recon, the color change is due to RBC lysis. The RBCs disintegrate entirely. In the aftermath, a persistent dense fibrinopurulent exudate dominates. The cellular status is now filled strictly with fibrin and dead or dying neutrophils. Finally, we hit stage 4, resolution from days 8 and beyond. The gross profile is a beautiful restoration of normal lobar architecture. Looking at the microscopic recon, the cleanup crew arrives. Alveolomacrophages return to enzymatically liquefy and phagocytose the consolidated fibrin. During clearance, this debris is digested or coughed up. Concurrently, rebuilding occurs as type 2 pneumocytes regenerate the epithelial lining. Now let's crack open the examiner's playbook with trap number 1, the Klebsiella currant jelly vignette. Your trigger words on an exam will be an alcoholic, malnourished, or a diabetic patient presenting with an upper lobe lobar pneumonia. The signature sign is currant jelly sputum, meaning it is thick, bloody, and gelatinous. The pathology correlation here is that Klebsiella pneumoniae possesses a massive, thick polysaccharide capsule that produces abundant mucoid slime. The consequence of this is that it triggers severe necrosis and lung abscesses much faster than pneumococcus. Moving to trap number 2, the post-viral superinfection. Step 1 is the primer. The patient catches influenza or the flu. Step 2 is the damage. The viral infection strips away the protective ciliated mucociliary epithelium. Step 3 is the crash, usually around day 6. The patient suddenly develops a high fever, rapidly progressive bronchopneumonia, and multiple lung abscesses. The golden rule here is when the flu rolls out the red carpet, pick Staph aureus. Let's wrap up with a synthesis, the diagnostic algorithm. If you see rigor plus rusty sputum plus a lobar block, target lock on Streptococcus pneumonia, causing over 90% of these cases. If you see an alcoholic plus an upper lobe consolidation plus currant jelly sputum, lock on Klebsiella pneumoniae and its mucoid capsule. If you see a post-flu crash plus patchy bronchopneumonia, lock on Staph aureus as a superinfection. The perimeter is breached, but your diagnostics are secure. Keep crushing those question banks and keep conquering pathology. Next, we are jumping straight into what I call the walking ghosts, the interstitial pathogens of atypical pneumonia. This is an extremely high yield topic for your MBBS, NEET-PG and USMLE Step 1 exams. Let's get started. Let's dive right into case vignette 5.2, the walking pneumonia mystery. Looking at the patient chart, our patient profile is a 19-year-old university sophomore living in a crowded dorm. For his symptoms, he has had 2 weeks of low-grade fever, headache, myalgias, and a dry hacking cough. But when we look at his physical exam, he feels entirely fine. He actually walked to the clinic. He has normal breath sounds and his percussion is resonant. However, his imaging reveals diffuse bilateral reticulonodular infiltrates. So why do we call it atypical? It is because these pathogens are breaking the classical rules. Think of typical pneumonia as being inside the tent. Its target is the alveolar spaces and the clinical result is alveolar consolidation, which presents with dull percussion, purulent sputum, and a high WBC count. Now contrast that with atypical pneumonia, which targets the walls of the tent. Its main target is the interstitium or the alveolar septae. The mechanism is that invaders attach directly to the respiratory epithelium and stop ciliary beating. The key clinical result is that the inflammatory cells are strictly in the walls, meaning the air spaces are empty. This perfectly explains the resonant percussion, dry cough, and normal WBC count we saw in our vignette. Now let's examine the microscopic proof. First, you will see widened septae. These are edematous alveolar septae that are physically expanded by inflammation. Second, you will find a mononuclear infiltrate consisting of lymphocytes, plasma cells, and histiocytes that are confined strictly to the interstitium. Third, you will see empty air spaces, meaning there are absolutely zero intra-alveolar neutrophils. Let's introduce the culprits, the atypical pathogens. First, we have Mycoplasma pneumoniae or the dorm room ghost. Second, Legionella pneumophila, the AC killer. Third, Chlamydia pneumoniae, the older adult echo. And fourth, the respiratory viruses which act as this viral swarm, including flu A and B, RSV, adenovirus, and SARS-CoV-2. Let's focus on Mycoplasma pneumoniae, which is the number one cause in young adults. The classic demographic includes school-aged children and young adults, particularly those in military barracks and dorms. The absolute most critical fact here is that it lacks a cell wall. Because of this, beta-lactam antibiotics like penicillin are completely useless. Here's a clinical goldmine for your exams. Cold agglutinins. Mycoplasma triggers the production of cold agglutinins, which are IgM antibodies. These antibodies bind to red blood cells tightly at cold temperatures. This results in localized hemolysis along with the Raynaud phenomenon. Next is Legionella pneumophila, the air conditioning killer. It loves warm, stagnant water such as cooling towers, cruise ship plumbing, and hospital nebulizers. For your exams, memorize this diagnostic triad. First, respiratory symptoms featuring an atypical pneumonia. Second, GI symptoms, specifically watery diarrhea. And third, metabolic and neuro symptoms presenting as confusion plus hyponatremia or low sodium. When it comes to staining and culturing the killer, remember that Legionella stains poorly with a standard gram stain and your routine cultures will be completely negative. Instead, you need a Dieter silver stain, which highlights the organism. Furthermore, a buffered charcoal yeast extract or BCYE agar is required for its growth. Completing the differential, we have Chlamydia pneumoniae. This is clinically identical to Mycoplasma, but it is seen primarily in older adults. Finally, our respiratory viruses, influenza A and B, present with seasonal peaks. RSV primarily targets infants and pediatrics. Adenovirus is common among military recruits and in crowded dorms. And SARS-CoV-2 causes COVID-19 viral pneumonia. Let's bring this all together with a high-yield synthesis of atypical pneumonias. For Mycoplasma, the target demographic is young adults and dorms. The key exposure is close quarters. Your buzzwords are cold agglutinins and Raynauds, and remember it has no cell wall, so beta-lactams fail. For Legionella, the demographic is older individuals and smokers. Key exposures are stagnant water and AC units. Buzzwords are diarrhea and hyponatremia, and your trivia is Dieter stain and BCYE agar. For chlamydia, the target demographic is older adults. There is no specific key exposure. It acts like mycoplasma for the old, And remember, it is an intracellular organism. Finally, for viruses, the demographic varies from infants to the elderly. Key exposures are seasonal or outbreaks. You will use specific viral assays relying on PCR and supportive care. Now pay close attention to Dr. P's exam cheat code. The Legionella trap. On your exams, if you see a 55-year-old smoker plus a stay at a convention hotel or cruise plus a severe pneumonia plus confusion plus watery diarrhea plus a serum sodium of 124 milliequivalents per liter, do not wait for cultures. Pick Legionella pneumophila. For treatment, administer a macrolide like azithromycin or a fluoroquinolone immediately. That brings us to case closed on the ghosts in the interstitium. Remember, atypical equals an interstitial attack, meaning the inflammation is in the walls, not these spaces. This results in a clinical presentation of normal RBC, resonant percussion, and a dry cough. For mycoplasma, think no cell wall, young adults, and cold agglutinin or IgM. For Legionella, think water sources, diarrhea, low sodium, and the need for detailed stain and BCYE agar. Next, we are exploring a topic I call the liquefied pit. We will be covering lung abscesses, aspiration, and the anatomy of necrosis. Let's get right into it. We begin with case vignette 5.3. Let's look at the patient context. We have a 54-year-old male with severe epilepsy and poor dental hygiene. He was found unconscious on his living room floor after a prolonged tonic-clonic seizure 2 weeks ago. His presentation includes spiking fevers, profound weight loss, and coughing up cupfuls of intensely fetid, foul-smelling brown sputum. Looking at his imaging, the chest X-ray reveals a 4 cm round, thick-walled cavitary mass with a distinct horizontal air fluid level, and it is located strictly in the superior segment of the right lower lobe. The clinical question is, what pathological process created this hole? Let's investigate the source of this mass, which is the aspiration of oral flora. This typically follows a loss of consciousness, such as seizure, an alcohol overdose, general anesthesia, or a stroke. While unconscious, filthy gingival crevice secretions slip past the glottis. This brings in what I call the hit squad, a group of mixed oral anaerobes. The key players you need to know are Prevotella, Fusobacterium, Bacteroids, and Peptostreptococcus. Why do these anaerobes take the path of least resistance into the right lung? Let's compare the anatomy. The right main bronchus is wider, providing easier access for infected sludge. It is shorter, meaning a faster transit to the lobes, and it is more vertical, meaning it directly follows gravity. Compare this to the left main bronchus, which is much narrower and sharply angled. This brings us to Dr. P's anatomical gravity rule, which dictates exactly where that sludge goes. If the patient is supine, meaning lying down flat, gravity pulls fluid posteriorly. Therefore, the sludge drains into the superior segment of the right lower lobe or the posterior segment of the right upper lobe. Notice how this perfectly matches a patient who was found unconscious on the floor. Now, if the patient is upright, meaning standing or sitting, gravity pulls fluid straight down. In that scenario, the sludge falls into the basal segments of the right lower lobe. Moving to the gross pathology, we are looking at the suppurative lung abscess. By definition, this is a localized area of liquefactive necrosis of the lung parenchyma caused by a suppurative infection. That necrotic core consists of foul yellowish-grey sludge aggressively destroying the surrounding lung tissue. What does this look like under the microscope? We see two distinct zones. First is the liquefactive necrosis core. This is a completely unstructured mass of dead leukocytes, liquefied necrotic parenchyma, and bacterial colonies. Second is the fibrous containment wall. As the abscess matures, fibroblasts build a thick barrier of granulation tissue and dense fibrous collagen to contain the destruction. Now for the process pathophysiology, why do we see an air fluid level? In step 1, the necrotic pit of pus grows under pressure inside the parenchyma. In step 2, the expanding cavity erodes into a patent bronchial tube. Finally, the patient violently coughs up half the liquid pus, which produces that fetid sputum. Once emptied, atmospheric air rushes in to fill the empty top half, creating the distinct horizontal line seen on the X-ray.
It is time for Dr. P's exam cheat code. When you see a lung cavity on an exam question, stop. Do not jump to conclusions. You must immediately run through the big 4 cavity killers. Let's look at the cavity differential for the big 4. First is a lung abscess. You are looking for foul-smelling sputum and air fluid level and a history of aspiration. Second is reactivation TB. Look for this in the upper lobe apex, accompanied by night sweats and caseating granulomas. Third is squamous cell carcinoma. Look for a central smoking mass, hypercalcemia, and central necrosis. Fourth is Klebsiella pneumoniae. Look for currant jelly sputum and rapid cavitary destruction. Let's bring this to our case 5.3 resolution. Looking at the history, a seizure combined with poor dentition led to the aspiration of mixed oral and aerobes. Looking at this location, his supine position directed the fluid perfectly into the superior segment of the right lower lobe. And looking at the imaging and symptoms, the cavity with an air fluid level and fetid sputum was caused by liquefactive necrosis eroding into the patent bronchus. Taking all this together, our final diagnosis from the chest X-ray is a suppurative lung abscess. Make sure to subscribe for more high-yield pathology masterclasses. As always, keep studying hard. Welcome back everyone to Module 5, Part 5. Today we are tackling the opportunists, focusing specifically on the intense world of ICU and fungal pneumonias. Let's get right into it. Let's start with the clinical vignette to set the stage. We have a 32-year-old male presenting with progressive, severe shortness of breath and a non-productive cough for last 3 weeks. Looking at his vitals, he is tachypneic, cachectic, and an ABG reveals severe hypoxemia. On your physical exam, you easily notice thick white scrapable plaques in his oral cavity. We run a routine sputum culture and it comes back completely negative. Looking at the imaging on screen, you can see bilateral ground glass perihilar opacities. So based on these clues, here's the question for you. What is the exact CD4 count of this patient? The diagnosis is pneumocystis jirovecii pneumonia or PCP. And if you guess the exact CD4 count, it is strictly less than 200 cells per microliter. This right here is the paradigm. PCP is the quintessential opportunistic infection of cell-mediated immunodeficiency, specifically seen in advanced AIDS. Let's look at the histology on an H&E and a GMS stain. The illusion here is that the organism does not actually invade the lung tissue. The mechanism is that it replicates strictly inside the alveolar spaces, which leads to a type 1 pneumocyte leak. On the H&E stain on the left, that leak creates the classic look, a foamy pink amorphous cotton candy exudate. But the truth is revealed on the right with a GMS stain, which highlights silver avid fungal cysts measuring 5 to 8 micrometer. Look closely at that morphology. They look like collapsed, crushed ping pong balls or tiny helmets popping right out of the foam. Now let's walk into the medical ICU and the bone marrow ward. We have a lineup of 3 main suspects to profile today: Aspergillus fumigatus, Mucormycosis or Rhizopus, and Cryptococcus neoformans. Suspect 1 is Aspergillus fumigatus. The target patients for this pathogen are those with neutropenic leukemia, patients who are post-chemotherapy, or those on chronic corticosteroids. When you look at its morphology on a slide, you are looking for septate hyphae with a uniform width of 3 to 6 micrometers. The dead giveaway is the acute angle branching, coming off at exactly a 45-degree angle. Aspergillus generally follows one of the 2 clinical trajectories. Path A on the top track is the invasive route. It becomes angio-invasive, directly leading to thrombosis and severe hemorrhagic infarction of the tissue. Path B on the bottom track is the cavitary route. Here the fungus colonizes a pre-existing empty TB cavity to form an aspergilloma, which is simply a fungus ball. Your key diagnostic finding on imaging is the Monod sign, also known as the air crescent sign, which visually indicates that you have a mobile fungus ball sitting inside that cavity. Moving on to suspect 2, mucormycosis or rhizopus. The target demographic here is highly specific: patients suffering from diabetic ketoacidosis or DKA and patients with severe neutropenia. Its morphology is completely different from Aspergillus. It is non-septate, meaning cenocytic, and forms broad, irregular structures up to 15 microns wide.
Notice the wide right angle branching at 90 degrees? They often look like twisted, crinkled ribbons on the slide. Mucormycosis is devastating, and you need to understand its lethal trajectory, the cranial vault breach pathway. Step 1 begins with a high glucose and acidosis environment, which is the classic DKA setting. In step 2, ketone reductase comes into play as mucor thrives in this iron-rich acidic serum. Step 3 is rapid aggressive angioinvasion, where the fungus pierces arterial walls, causing massive necrosis of the surrounding tissue. This culminates in step 4, the cranial vault breach, where the infection spreads directly through the cribriform plate and straight into the brain. Suspect 3 is Cryptococcus neoformans. The prime targets for this opportunist are AIDS patients and solid organ transplant recipients. Morphologically, we are looking at pleomorphic budding yeast rather than hyphae. Its major armor is an exceptionally thick gelatinous polysaccharide capsule. On the left, an India ink preparation shows clear halos surrounding the yeast against a dark background. On the right, a mucicarmine stain specifically targets and stains that capsule bright red. Here is your fungal diagnostic matrix to lock all of this into your memory. Aspergillus features a 45-degree acute branching angle, is septate, targets neutropenia and chemo patients, and its hallmark is the aspergilloma or air crescent sign. Mucor features a 90 degrees wide branching angle, is non-septate, targets patients with DKA and acidosis, and its lethal hallmark is cribriform plate invasion. Finally, Cryptococcus is a yeast without branching or septation, targets transplant and AIDS patients, and its hallmark is that massive polysaccharide capsule. Time for a tactical briefing on a common exam trap. Code 1 is the angle rule. Remember that Aspergillus equals an acute angle of 45 degrees and is septate. Mucor equals a maximum angle at 90 degrees and is non-septate. Code 2 is the PCP lab cheat. The classic clinical setup is an HIV positive patient with an atypical pneumonia, yet they have a completely normal chest auscultation. The trap the examiners will throw at you is an inexplicably sky-high serum LDH. Why does this happen? Because the massive fungal multiplication destroys the alveolar epithelial membranes, which immediately dumps massive amounts of LDH into the patient's serum. To conceptualize the immunocompromised lung, I want you to think of it as the upside down. Once the immune system guardian lights flicker out, these fungi drop their roots deep into the vasculature, literally transforming the thorax into a necrotic, infected alien landscape. Before we finish, let's zoom out and summarize the major pneumonia patterns. Lobar pneumonia is caused by Streptococcus pneumonia 90% of the time, spreads via the pores of corn, and progresses through 4 stages: congestion, red hepatization with rusty sputum, grey hepatization, and resolution. Bronchopneumonia is patchy, centered on the bronchioles, and usually involves S. aureus post-flu or Pseudomonas. Atypical pneumonia hits the interstitium and involves mycoplasma, which presents with cold agglutinins or Legionella linked to water sources, diarrhea, and low sodium. Aspiration pneumonia is right lung dominant and features an air fluid level due to liquefactive necrosis eroding the airway. And as we covered today, opportunistic pneumonia includes PCP when CD4 drops below 200, Aspergillus branching at 45 degrees, and Mucor branching at 90 degrees in DKA patients. And with that, Module 5 is officially complete. Up next is Part 6, Space Invaders, where we will dive into lung carcinomas, comparing small cell versus non-small cell, along with paraneoplastic syndromes, pleural effusions, and malignant mesothelioma. Finish strong, keep conquering those question banks, and as always, conquer pathology with Dr. P. Welcome back to Conquer Pathology. I'm Dr. P, and today we are entering Module 6, Space Invaders. Our core focus is the big 4 lung carcinomas, their molecular genetics and diagnostics. Let's establish the clinical stakes right away. Lung cancer is the #1 cause of cancer-related mortality worldwide for both men and women. The reason it's so lethal is because the lung is a sprawling, low-density cavern. It is a silent threat that allows tumors to grow completely unnoticed. By the time a patient presents with symptoms like a cough or hemoptysis, over 70% of these tumors have already breached the pleural perimeter and metastasize to the brain, bone, liver, or adrenals. Let's look at two patients who represent two entirely different genetic universes. Patient A is a 64-year-old male and a heavy smoker who presents with hemoptysis. His bronchoscopy reveals a friable ulcerated mass completely occluding the right main bronchus. Now look at patient B. She is a 42-year-old female marathon runner and a never smoker. She presents with an incidental finding on a rib CT which shows a 3 cm spiculated nodule sitting way out in the subpleural periphery of the left upper lobe. Both patients have primary lung carcinomas, but what exactly are they? To answer that, you need to understand the oncospatial paradigm. Lung tumors are categorized by where they take root. Central tumors originate in the large airways, the trachea, primary, and segmental bronchi. They are triggered by heavy smoking and cause early airway obstruction and wheezing. The culprits here are squamous cell and small cell carcinomas. Peripheral tumors, on the other hand, originate in the terminal bronchioles and alveoli. They grow silently until pleural invasion occurs. The main culprit here is adenocarcinoma. Let's break down the peripheral culprit first, adenocarcinoma, which I call the peripheral queen. Epidemiologically, this is the number 1 lung cancer overall, making up about 40% of all cases. It is also the most common lung cancer in women, non-smokers, and patients under 45 years old. On histology, you are looking for a malignant glandular proliferation that actively produces intracellular mucin. If you run immunohistochemistry, your defining biomarkers are a positive TTF1 and a positive nepsin-A. How does adenocarcinoma develop? It follows a specific precursor pathway, beginning as atypical adenomatous hyperplasia, progressing to adenocarcinoma in situ, and finally becoming invasive adenocarcinoma. The defining feature of adenocarcinoma in situ is the lipidic pattern. This is where malignant columnar cells literally crawl along the pre-existing normal alveolar septae. The visual mnemonic I want you to remember is butterflies sitting on a fence. The crucial rule here is that there is absolutely zero stromal invasion. The underlying alveolar architecture is strictly preserved. Because adenocarcinoma often strikes non-smokers, we have to look at the targeted therapy tree. For non-smokers, the tumors are driven by specific targetable mutations. If you see an EGFR mutation, like an exon 19 deletion or L858R, you target it with erlotinib or osimertinib. If there is an ALK rearrangement, specifically the EML4 ALK fusion, you use crizotinib or alectinib. You also want to look out for ROS1 fusions. Conversely, in smokers, the tumor has a massive mutational burden, often driven by KRAS mutations, which historically have been untargetable and carry an extremely poor prognosis. Moving back to the central airways, we have squamous cell carcinoma or the smoker's pit. This accounts for 20 to 25% of cases and is found almost exclusively in male heavy cigarette smokers. It arises strictly in the large central bronchi. Its precursor pathway is driven directly by the smoke, progressing from squamous metaplasia to dysplasia and then into carcinoma in situ. The gross hallmark on imaging or autopsy is central cavitary necrosis. This happens because the tumor grows so aggressively that it rapidly outgrows its own blood supply. Your clinical rule? A smoker with a cavitary mass is a squamous cell until proven otherwise. Under the microscope, squamous cell carcinoma has two architectural hallmarks you cannot miss. First, keratin pearls, which are concentric whorls of brightly pink extracellular keratin. Second, intercellular bridges, which are visible desmosomal attachments physically connecting the adjacent tumor cells. For your biomarkers, these tumors will be strongly positive for P40 and CK56 and strictly negative for TTF1. Next is the most dangerous of them all, small cell lung carcinoma, the neuroendocrine wildfire. It makes up 15% of cases, but it is the most aggressive and exceptionally lethal tumor we see. 99% of these patients are heavy smokers. It is strictly central, usually presenting as a massive hilar or mediastinal mass. At a cellular level, it originates from the neuroendocrine Kulczycki cells lining the bronchial mucosa. Genetically, this tumor is an absolute disaster. It features biallelic inactivation of both TP53 and RB1, supercharged by MYC amplification. The histology of small cell is frantic. The base morphology shows dense sheets of blue cells with practically no cytoplasm, commonly called oat cells, and they have an exceptionally high Ki67 proliferation index of over 90%. Look at the nucleus. It has salt and pepper chromatin, which is finely granular with zero visible nucleoli. Because they replicate so fast, you will see nuclear molding, where the cells physically squeeze and mold perfectly against one another. Finally, the boat slam dunk is the azoparty effect. Intense dark blue basophilic staining of local blood vessel walls. This happens because the massive amount of necrotic tumor DNA literally spills out and encrusts the vascular elastic fibers. The final of the big four is large cell carcinoma, often referred to as the trash can diagnosis. By definition, it is an undifferentiated malignant epithelial tumor. The golden rule is that this is a diagnosis of exclusion. It lacks the glands and mucin of adeno, it lacks the keratin pearls of squamous, and it lacks the neuroendocrine features of small cell. Morphologically, you just see giant, highly anaplastic, bizarre multinucleated cells. Clinically, it has a variable peripheral location and an extremely poor prognosis. Let's consolidate the lab work with the IHC biomarker master panel. If the biopsy is adenocarcinoma, it will light up for TTF1 and napsin A. If it is a squamous cell, you are looking for P40 and CK56. If it is a neuroendocrine small cell tumor, it will be positive for synaptophysin, chromogranin, and CD56. Here's your overarching diagnostic matrix. Use this slide to review the entire landscape. Adeno is peripheral, seen in non-smokers and women, with glands and TTF1. Squamous and small cell are central and tied heavily to smokers. Squamous gives you keratin pearls and P40, while small cell gives you oat cells, the azoparty effect, and neuroendocrine markers. Large cell is your peripheral, undifferentiated diagnosis of exclusion. Before we finish, let's look at a few exam cheat codes and traps. First, the location mnemonic. Remember that central starts with an S, which covers squamous and small cell. Peripheral starts with a P for paragliding adenocarcinoma. Second, do not fall for the targeted therapy trap. If a clinical vignette shows an EGFR mutation positive adenocarcinoma biopsy, do not select traditional cytotoxic chemotherapy. You must select an EGFR tyrosine kinase inhibitor like osimertinib. The examiners demand horizontal integration of pathology and pharmacology. And with that, the big four carcinomas are mapped and diagnosed. Up next in series, we are exploring paraneoplastic syndromes, pleural effusions, including Light's criteria, and malignant mesothelioma. Keep crushing your studies and make sure to subscribe. And as always, conquer pathology with Dr. P. Welcome back. Next, with case 6.3, the young flusher, we are going to be completely demystifying bronchial carcinoids. Let's get started. We begin with the presentation. We have a 28-year-old non-smoking woman. She presents with recurrent episodes of coughing up blood and a localized wheezing in her right lower lung field that has actually been misdiagnosed as asthma for the past 2 years. But here is the critical change. Recently, she started experiencing episodic dramatic flushing along with explosive watery diarrhea. This clinical picture tells us a few things immediately. The fact that she is a young non-smoker rules out small cell and squamous cell carcinomas. The localized wheezing points to a mechanical airway obstruction, often called a ball valve effect. Finally, the flushing and diarrhea point directly to a systemic vasoactive amine release. Let's look at the macroscopic evidence. A chest CT reveals a 2 cm highly vascular polypoid mass that is protruding directly into the right lower lobe bronchus. Let's break down this diagnostic insight. The tumor is highly vascular, which perfectly explains her recurrent hemolysis, or coughing up blood. And because it is a polypoid mass sitting directly into the lumen, it causes that localized wheezing that was originally misdiagnosed as asthma. Now we put it under the microscope. Bronchial carcinoids have a distinct neuroendocrine signature. As a quick takeaway, these account for only 1 to 5% of all lung neoplasms. The mean patient age is 40, and crucially, there is absolutely no relationship with cigarette smoking. When you look at the histology on the screen, you are looking for specific architectural patterns. You will see them arranged in organoid nests, linear trabeculae, and circular rosettes. Zooming in even closer to the cells, we find the nuclear signature. What you see here is the classic salt and pepper chromatin. This finely speckled appearance is the uniform textbook nuclear presentation of a neuroendocrine tumor. Now we have to classify it using the Robbins prognostic tiers, which divide these into typical versus atypical carcinoids. A typical carcinoid has a mitotic count of strictly less than 2 per 10 high power fields, zero necrosis, and features an excellent 10-year survival rate of over 85%. An atypical carcinoid has 2 to 10 mitosis per 10 high power fields, focal punctate necrosis, and a much more aggressive behavior with lymphatic spread. For our patient, the case conclusion is clear. Her biopsy showed zero mitosis. The diagnosis is a typical bronchial carcinoid. But here is the systemic mystery we need to solve. We know these neuroendocrine tumors secrete massive amounts of serotonin or 5-HT, but if her primary tumor is located in the lung, why is she only experiencing the explosive diarrhea and flushing now? To understand this, we have to look at state 1, the MAO firewall. Normally, when serotonin from the gut enters the portal circulation, the liver acts as a metabolic firewall. An enzyme called monoamine oxidase or MAO aggressively degrades that serotonin as it passes through. The result, no active serotonin reaches the systemic blood, which means the patient does not experience carcinoid syndrome. But our patient has entered state 2, the hepatic breach. The mechanism here is that the tumor has metastasized to the liver. Because the metastatic cells are sitting inside the liver, they dump 5-HT directly into the hepatic vein. This entirely bypasses the gut and liver MAO degradation process. Massive amounts of serotonin flood straight into the systemic circulation, and the result is a triggered carcinoid syndrome. This leads us to the clinical symptoms of carcinoid syndrome, which is effectively a 5-HT tsunami in the body. You will see dramatic flushing due to sudden face and neck vascular dilation. You will hear bronchospasm from smooth muscle contraction. You will see explosive watery diarrhea caused by extreme GI hypermotility. And most dangerously, it causes right-sided valvular fibrosis because the tricuspid and pulmonic walls are bathed in raw serotonin right before the lungs finally get a chance to metabolize it. Let's bring the complete picture together from pathology to the patient. It starts with a primary mass, a 2 cm polypoid typical carcinoid in the right lower bronchus, causing that localized wheezing and hemoptysis. The trigger occurs when a liver metastasis bypasses MAO degradation, dumping serotonin directly into the hepatic vein. This leads to the new clinical presentation of episodic flushing and explosive watery diarrhea. Ultimately, if left unchecked, this leads to the severe complication of right-sided valvular fibrosis due to systemic 5-HT exposure. And that wraps up case 6.3. Next in Module 6, we are specifically tackling pleural space emergencies. By the end of this session, you will have completely mastered pleural effusions, Light's criteria, and the lethal mechanics of pneumothorax. Let's dive in. We start with case vignette 6.4, the stony dull base. Our patient is a 60-year-old male presenting with progressive shortness of breath and a heavy sensation in his left chest. On physical exam, his percussion is a stony dull. His tactile fremitus is completely absent, and his breath sounds are distinctly muted. Look at the X-ray on the screen. You can clearly see the classic meniscus sign indicating significant fluid accumulation. We perform a diagnostic thoracentesis and yield 500 milliliters of straw-colored fluid, which is immediately sent off to clinical biochemistry. Our goal now is to mathematically prove the exact nature of this fluid. Is it a transudate, which represents a relatively harmless hydrostatic backup? Or is it an exudate, pointing towards sinister inflammation, cancer, or an active infection? To answer this, we enter the gold standard of respiratory medicine, Light's criteria. The rule is simple, but absolutely critical. The pleural fluid is classified as an exudate if it meets any one of these 3 specific criteria. Number 1, the ratio of pleural fluid protein to serum protein is greater than 0.5. Number 2, the ratio of pleural fluid LDH to serum LDH is greater than 0.6. Or number 3, the absolute pleural fluid LDH is strictly greater than 2/3 of the upper limit of normal for serum LDH. If even a single one of these equations is met, you are dealing with an exudate. Let's log this in with the direct matrix. For an exudate, Light's criteria is positive, meaning one or more conditions are met. Pathophysiologically, this is driven by active inflammation causing leaky capillaries. The classic causes you must know are cancer, pneumonia, and tuberculosis. On the flip side, a transudate is strictly negative for Light's criteria. The pathophysiology here is simply a hydrostatic pressure backup. The classic causes are congestive heart failure, cirrhosis, and nephrotic syndrome. Now let's transition from fluid to air. We are going to explore the mechanics of pneumothorax. Because while we spend a lot of time analyzing what fluid does inside the pleural cavity, we must never forget the devastating rapid potential of trapped air. First up is the primary spontaneous pneumothorax. The classic presentation is a tall, thin, young, athletic male. He literally just takes a normal breath, and the pneumothorax says, "Allow me to introduce myself." The physiological mechanism here is that high shear stress at the very apex of the lung causes the sudden rupture of subpleural apical bullae. Contrast that with the secondary spontaneous pneumothorax. Here the culprit is chronic, it is COPD and severe emphysema. The mechanism is the rupture of pre-existing emphysematous bullae. Unlike the primary variant where the lung is healthy, in a secondary pneumothorax you can see that the underlying lung architecture is already profoundly destroyed. Next, we face a true terrifying medical emergency, the tension pneumothorax. This acts as a lethal one-way valve in the chest. On inhalation, a damaged tissue flap opens and air rushes directly into the pleural space. But on exhalation, that tissue flap closes tight shut, the air cannot escape, it is permanently trapped. This trapping immediately triggers what I call the lethal shift. Step 1. The trapped air volume relentlessly increases with every single breath. Step 2. The intrathoracic pressure skyrockets. Step 3. The mediastinum, including the heart and trachea, is forcefully pushed to the opposite side of the chest. Step 4. That massive pressure physically crushes the superior vena cava. And step 5. Venous blood return to the heart drops to absolute zero, resulting in instantaneous cardiac arrest. How do we stop the lethal shift? The fix is an immediate needle decompression. Your exact anatomical landmark is the second intercostal space at the mid-clavicular line. Listen to me carefully on this. Do not wait for a chest X-ray. Tension pneumothorax is a clinical diagnosis. You must act immediately on what you see to save the patient's life. Let's finish up with Dr. P's high-yield cheat sheet. Remember Light's criteria: a protein ratio over 0.5, LDH ratio over 0.6, or absolute LDH over 2/3 the upper limit of normal. If anyone is positive, it's an exudate from inflammation or cancer. If 0 are positive, it's a transudate from hydrostatic backup. For spontaneous pneumothorax, primary hits tall, thin males via apical blebs, while secondary hits COPD patients via ruptured bullae. Finally, tension pneumothorax is a lethal one-way valve that crushes the SVC. Your immediate fix is needle decompression in the second intercostal space mid-clavicular line. And that concludes our masterclass on pleural space emergencies. Next in our series is the grand wrap-up. We are taking on malignant mesothelioma and equipping you with the visual architecture and diagnostic cheat codes you need to absolutely dominate respiratory pathology. Let's get to work. Let's jump right into case vignette 6.5, the 40-year time bomb. We have a 74-year-old retired naval insulation contractor. He presents with severe, unrelenting pleuritic chest pain and dyspnea. Look at the radiological crime scene. There is a dense, irregular pleural mass encasing his right lung like an orange rind, with direct extension into the interlobar fissures. We take a biopsy and get a preview of what's inside. A biphasic tumor showing both malignant glands and swirling sarcomatoid spindle cells. To understand this presentation, we have to look at the genetic time bomb, specifically amphibole inhalation. In 1980, this patient inhaled amphibole asbestos needles. After a massive latency period of 25 to 45 years, we are now seeing the malignant mesothelioma explosion in 2026. A massive high yield point for your exams: cigarette smoking does not increase the risk of mesothelioma. On a molecular level, this cancer is driven by the asbestos-induced deletion of the CDKN2A or INK4A tumor suppressor locus, also known as P16/ARF combined with BAP1 mutations. Looking at the gross pathology, we see the signature encasement. The visual metaphor I want burned into your brain is the rind of an orange. The key diagnostic features are a thick, firm, white grey tumor that completely encases the entire lung, with direct extension deep into the interlobar fissures. The clinical consequence of this is devastating. Complete mechanical restriction, massive atelectasis, and that unrelenting pleuritic pain our patient experienced. Under the microscope, we witness a lethal dual personality. First, the epithelioid component, which forms malignant glandular spaces lined by cuboidal cells. Second, the sarcomatoid component, composed of swirling, densely packed spindle-shaped cells. Together, these confirm our primary diagnosis of biphasic mesothelioma. But here is the diagnostic danger. That epithelioid component looks dangerously identical to peripheral metastatic lung adenocarcinoma under standard H&E staining. This brings us to the pathologist's ultimate headache. Both tumors form identical-looking malignant glands in the pleural space, meaning morphology alone is simply not enough to differentiate them. We need higher-level tools. We use two main weapons. Weapon 1 is immunohistochemistry or IHC panels. Mesothelioma is generally positive for calretinin, WT1, and CK56. Adenocarcinoma is positive for TTF1, Nepsin A, and Bayer EP4. Weapon 2 is electron microscopy. Mesothelioma features long, slender microvilli, while adenocarcinoma has short, sparse microvilli. Let's dive deeper into Weapon 1, the IHC marker standoff. On the left, we have the pleural defenders, mesothelioma. These cells will predictably stain positive for calretinin, WT1, D240, and cytokeratin 5-6. On the right, we have the invaders, adenocarcinoma. These will stain positive for CEA, TTF1, Claudin 4, and Bayer EP4. You must memorize this specific standoff. When IHC panels return ambiguous results, we deploy Weapon 2, electron microscopy, and the microvilli rule. For mesothelioma, you will see exceptionally long, slender, bushy microvilli with abundant tonofilaments. For adenocarcinoma, the microvilli are short, stubby, and plump with prominent core rootlets. Here's your memory trick. Mesothelioma has magnificent, majestic microvilli. And with that, we reach the grand audit. We have conquered anatomy, physiology, lung carcinomas, pleural disease, diagnostics, and staging. I want you to drop your pens, take a massive, unatelectic, fully surfactant-coated breath of air. You have completely conquered Robbins Chapter 15. Now we are initializing a lightning-fast recap of the highest yield associations for lung carcinomas and pleural disease. Here are your living cellular stories. The carcinoma cheat codes. Adenocarcinoma is peripheral, seen in non-smokers, features a lipidic AIS pattern, is TTF1 positive, and has targetable EGFR or ALK mutations. Squamous cell carcinoma is central, strictly in smokers, features keratin pearls, intercellular bridges, and cavitary necrosis, with PTHRP causing hypercalcemia and a positive P40. Small cell carcinoma is central, neuroendocrine with Kulczycki cells, shows the azopardi effect, triggers paraneoplastic syndromes like syndrome of inappropriate antidiuretic hormone or Cushing, and is driven by TP53 and RB1 mutations. Finally, carcinoids are low-grade tumors presenting with typical features if there are less than 2 mitoses, atypical if more than 2, and can trigger serotonin flushing. Next in our recap, pleural exudates and diagnostics. Remember Light's criteria? If any one of these is true, you have an exudate. Pleural fluid protein to serum protein ratio over 0.5, pleural fluid LDH to serum LDH ratio over 0.6, or pleural fluid LDH greater than 2/3 the upper limit of normal serum LDH. Finally, your mesothelioma master summary. The gross pathology shows an asbestos encasement rind. Electron microscopy reveals long slender microvilli, and IHC is decisively calretinin positive. You now possess the exact visual architecture, molecular mechanics, and diagnostic cheat codes to dismantle any respiratory question they throw at you. Remember, the lung is the interface between the soul and the sky. Make sure to subscribe, share this with your batchmates, keep revising, and as always, conquer pathology with Dr. P.